helpful. But kids are so individual, and Valery Alexeyevich will speak of this. Infants with a body mass of less than 1 kilo, they are absolutely different. You cannot, kind of treat them the same way. They are absolutely different. For instance, the peak pressure to create a very small guaranteed volume was 79. We would never have thought about it, and our protocols are developed in such a way that we should do the same thing for all the kids. But this is going to be too much for one, and that is going to be insufficient for others. And we try to develop today different grounds and conditions for violating different rules and regulations. And this is something that we all should do to save our children and so that they can then function fully. And also from the point of view of the concentration, for instance. So, the alpha low concentration, this actually reduces the damage of the brain. So this is the conclusion that we have come. I know that I have used more time than I was given, but I just wanted to stress one point. Such an infant, he is so small. He has to be given birth at the perinatal center. Perinatal centers are well equipped for taking care of all the problems. And in our country, we try to use the very sparing approaches, maximum transportation. Maximally, we have to avoid transportation of such children between different organizations and institutions. So we have to understand the most weak places, painful points, so to say, bottlenecks in this continuum of caring of such a child. And open resuscitation, and I will speak of this later. This is also a very important thing, but we have to discuss it separately. I thank you for your kind attention. I will answer your questions, if any. Please ask them to the microphone. We have 3 minutes for questions. If you have questions, please ask them to the microphone, please. Thank you. The question is off the mic. Well, we had 128 kids last year with a body mass of less than 1 kilo. And the survival is for 85%. And as for the kids with the body mass of 500, so their survival is lower. And I understand for myself, from year to year, the situation may change, and to a large extent, we depend on many external factors. And from the point of view of helping children, for instance, this influence of COVID, for instance, it of course influenced the outcome in many cases. Please ask your questions to the mic. The question is not heard. And our perinatal center is working in such a way that we do not want to have transfers between different organizations and institutions. And talking about Hospital 67, for instance, we normally try to take care of them only in our hospital. Transportation is a shock for them, and we have to do this only when it is absolutely important. So that's our policy. Practically all kids whom we have taken care of, they have been discharged home. Well, the results are great. Thank you very much. Thank you. Congratulations. Thank you. Any questions?
It's wonderful. My question to you is, do you have normative database of full-term delivery? What's the birth weight within your population? Because I think the way you presented it, data coming from different countries and different population varies a lot. And coming from India, I can say we do see those values coming from the other studies doesn't match very well in terms of what's the normal full-term birth weight. And I think that will be meaningful to extrapolate data, what should be expected at 22 weeks, 25 weeks, etc.
Мне нужна помощь немного в 2 словах. Я утратила.
trying to repeat the question. Because otherwise we have to somehow bring to the common denominator so that we can compare data coming from different countries. The question is off the mic. Is there a legislative database? A very interesting question. Thank you very much. I excluded several slides from my presentation, and they were on the population peculiarities of the body mass that is lower than 1 kilo. And I compare them with the Irish data. They have been published. That's the reason why I compared them to the Irish from Ireland. And so, for instance, no ratios such as, for instance, the gestational age and the number of weeks, and what we analyzed for the regions in several years for Moscow. So we saw that our figures are a little bit higher. For instance, gestational age compared to Ireland was 50 to 100 gram more. The Irish would give us 500, 600 for 22 days and weeks, and for us, it was a little bit different from that. And I agree with you that we have to have the common grounds for comparing things. And at present, we are trying to take care of kids of less than 500 grams.
You said that one of the problems is what to get oriented to the period of gestation or to the weight. And then you said that you see a very big individual variability. I also saw one of your slides where you made an assessment by indicators of physical maturity and functional tests. As a physiologist, I immediately begin to think that apart from two very averaged indicators of weight and period of gestation, it is necessary, especially having such a big individual diversity, to strive for some integral indicator of the morphological maturity of a specific child. What can you say about it? Is there such an approach that complements the gestation and weight? And what would you look to in such tests? What functions, what functional systems, maturity, level of maturity that can be a more determining factor than gestation and weight? Well, a very difficult and a huge question. Our assessment of possibilities are very limited. We can use a clinical scale orienting to the external factors that can give us that this is an premature child, so it's the hair, the soft ears, for example. That's all that allows us to assess the functional ability of such a person with such small weight and early period. We do not have any diagnostic criteria that are not invasive, because you understand that any invasion in such a human is very dangerous. That's why I won't give you an objective answer. Being clinicists, we always look at the skin, how mature it is. It defines the outcome, whether his eyes are open, and that all increases maturity. To what extent the patient is able to fulfill other functions, whether he accepts the gas exchange that is imposed, what is his function of kidneys, of the heart. That can be assessed. That is realistic, and this is very important. Yes, but we need to work very scrupulously with that, because children, kids, infants are very different. If they are a bit frozen, adults do not notice it, for example, 36.5 or 36.1. We don't differentiate, but it is very important for this infant. He is very much dependent on the changes in the environment. Anton Sergeyevich, you are welcome. In fact, these data are fantastic. I would like to draw the attention of our foreign colleagues to the fact that this experience of caring for children under 500 milligrams, well, it is possible only when you have a very good route of such kids who get from the very beginning to the proper prenatal center. And of course, it is also we are interested in the method of birth. How do these deformities, how do these damages will affect the child's future life? I would like to hear your opinion. To hear about the period of 24, 23, 24. Does the method of birth, whether it is cesarean incision, does it affect the outcome, or it doesn't affect the survival? It's a very discussable issue. And recently, I was making a report on this the subject, and that's why I studied it very deeply, looked at the obstetrician's protocols. My opinion is that there is no clear answer to this question. Whether it is natural birth, it gives quite good results, and cesarean also gives good results. Cesarean is not a reason if we decide to care for the child. But children before 24, 25 weeks, the natural birth is quite dangerous. It is maybe traumatic for the child. We often see such infants. They have hemorrhages on the skin. In this case, well, I did not analyze this problem, but if these manifestations are seen on the skin, you may predict some problems with the head, with the brain. So let us pass over to the next presentation. Variability of the heart rate of the fetus and neonatal outcomes. The presentation will be made by Dr. Martirosyan. Good afternoon, good morning, dear colleagues, dear Konstantin, dear chairs of the conference, dear guests and colleagues. I would like to present a report that is connected with the previous presentation and with the general topic of our conference, but it relates more not to the premature infants, but to the presence of ischemic neopathology in premature kids. This problem has a very important social component, and by the data of NHS system in Britain, the largest number of claims against doctors refers to two problems. Mistakes in interpreting the ECG and the cerebral palsy in infants after the birth in premature children. In the Russian Federation, the largest claim for such mistakes is about 15 million rubles. The largest one was for 15 million rubles. At that time, it was $500,000, and that was a claim associated with the events during the birth that led to the cerebral palsy. And epidemiological research that was conducted in the world shows that up to 10% of cases on neonatal encephalopathy is connected with the hypoxia in the fetus. 25% can have some adjacent factors. Up to 70% of cases of encephalopathy connected with do not have anything to do with hypoxia, and neonatologists should know it very well, because otherwise we may have different mutual claims. 70% include such problems as the delay in the growth of the fetus, multi-fetus pregnancy, and congenital defects of development. Speaking, if hypoxia took place intranatally during the labor, we may say that these factors include such indicators as pH, arterial pressure, and the higher indicators do not reduce this factor. So, and in many cases, hypoxia does not play any role in the development of encephalopathy. So even patients who are born with low indicators, like pH or higher indicator of deficiency, still most of them do not have unfavorable neurological outcomes. What is the first method of intranatal observation? Here you see the results of the trial, that the comparison of such monitoring as auscultation, computer assessment, definition of the lactate of the blood from the head, and analysis of CT segments in direct ACG. So they demonstrate that none of the methods of neonatal observation does not reduce the frequency of cesarean, because all the approaches that obstetrician used for natal observation was done to find the main approaches for the time and method, the time of birth and the method of birth. And all the studies are done in this context. That's why there is not a single study, not a single trial that could be unique in this case. Since 1970, such test as a cardiotocography has been developed to define the acidosis in the child, to suspect it, hoping that the operative invasion would reduce mortality. But there is one problem here. This method has acquired sensitivity and specificity. Low sensitivity and high specificity, so the fetus feels quite well, but if it is abnormal, that doesn't mean that he feels worse. Yes, that's why the comparison of these two elements allows us to standardize the problem of interpretation. And the images that I will be showing are the images that we collected for many years, studying the anamnesis of patients for the future and the further neurological outcomes. Now you see that low sensitivity, only 0.17 of children had severe cerebral palsy, and then that shows the high false result, and that led to the situation that until now we have no consensus on the on this issue. Here you see leading obstetrician associations in Europe, in United States, offer their own protocols of interpreting cardiotocograms. They are similar, but in some respects, but different in others. Cardiotocography does not, it reduces the frequency of encephalopathies in children and convulsions, and it doesn't affect any damages in the brain that happen in the prenatal period. So all these images were received in different years, and comparing them with further outcomes, low variability shows such a pathology of the brain, the retardation of the development of the fetus, and intratom arrhythmia. Frequently, children with low variability had the austhenic spectrum disorders. As to the cyclicity, so cyclicity up to 40 is replaced by medium rates, and it shows the normal neurological state that the newly born will have. Hypoxemia and acidosis was not observed in case of the cyclicity. So here you hear this early, the increased variability, more than 25 strikes a minute. It is an early unfavorable quality that reflects the reaction of the vegetative nervous system. Speaking about tachycardia, this is an absolute or relative increase of the heartbeat during the birth is very rarely connected with the hypoxia of the fetus. And early hydration is one of the best clinical practices. Tachycardia and absence of variability reflect the earlier existing neurological damages. And here we may think about unfavorable outcomes. Sinusoidal rhythm. It was described in fetuses with anemia, but then it was proved that it is connected with the heavy hypoxia and sepsis. Here you see the data that we have received. The sinusoidal rhythm and low variability are quite serious predictors for the death of the fetus during labor. So here I show you different types of sinusoidal rhythm. You see here saw-like forms and rhythm in late decelerations connected with the oxygen transfer through placenta. Usually in here we require an immediate birth, depending on the stage of the birth. Yes, variable decelerations can also have an effect on our decision. They are connected with the ischemia of the brain, and it may also lead to the death of the fetus. Bradycardia. So the connection, bradycardia over 10 minutes with the low level of pH and with the further neonatal encephalopathy. So it may arise during the birth, and it can be connected with the medical technogenic disorders due to the excess oxytocin. And this is also a way to the death of the fetus. Speaking about the duration of hypoxia, what time period we have to solve the problem after the first signs and to avoid deformities of the brain. So there were two pools of studies. The first was made on animals, on monkeys, on sheep. This slide shows the trial that was made on monkeys and demonstrated this they pressed the ubicus, and so they studied what time interval gave rise to the damage of the brain, leading to the heavy neurological deficit in monkeys. It was 15 minutes.
Second stage of studies was done with patients with the rupture of the uterus during the labor, during the delivery. A very interesting study done by the Norwegian colleagues, and they demonstrated that time more than 20 minutes, this gap can actually result in very serious ischemic, hypoxic, encephalopathy in a newborn. So these are the pictures and diagrams that I already showed you. So these are the clinical cases when actually you don't have time. You don't have any time at all. What can we do? The intrauterine resuscitation. And then partially these clinical practices will help. We change the position of the mother's body. We also do inhalation of oxygen. Of course, we cannot spend too much time for all these methods, but they can a little bit elongate the time for the safe delivery, for the safe labors. And of course, it is absolutely important at present, such things like venous administration of the fluid. Also, we have to do the saturation with oxygen of the fetus as high as possible, and also inhale of oxygen we do through mask or in different other ways. And this is the intravenous hydration. This is very important for oxygenation of the fetus. Inhalation of oxygen is absolutely reasonable when treating such kids. And this is the computer analysis. What do we do? At present, due to certain sanctions against the Russian Federation, we in medicine do not have access to this technology. Unfortunately, the hardware of this class, we expect them to come to the Russian market from our Chinese colleagues, and we look forward to having them. And we plan to develop this technology, which is going to be very helpful. And for instance, International Federation of Gynecologists, this is the most respectful organization, so they indeed use technology as much as possible because it is important to effectively assess the status of the intrauterine fetus. As for the pulse oximetry of the fetus, we did it ourselves as well, and we have heard about this and we have read about it. We do have some experience of our own. However, unfortunately, and this corresponds to the data from the Cochrane report, unfortunately, our results were far from being absolutely good. And the variability is very high, 35 to 65 about the saturation with oxygen, no correlation whatsoever with the ultimate neurologic outcomes, and also according to the Apgar scale. And so this is something that we have to admit. And this is the procedure which we make use of. This is determination of the lactate of blood from the skin and the head of the fetus at present. We determine the pH and the blood lactate. So this is something which indeed has a very serious niche for it, and at present we do not have the technology that I was talking about. We do more of the determination of blood lactate, and then we can identify patients who do not have too big a deviation from the normal topogram. And I thank you for your kind attention. And the subject of our conference is such important and such long term that I hope that we will have a chance to discuss it at many other meetings. Thank you very much. Thank you. Konstantin, we have time for one question only. Please ask it to the mic. Thank you very much. First, thank you very much. It's been very impressive. The slide that none of the methods of intranatal follow-up gives us any effect for the solution of the problem of the cesarean section. I understand that there may be two factors. First, so very many cases when this is done, and whether or not it can be used extensively. And second, the feasibility. If you ignore these two factors, then on the basis of your experience, do you think that there might be some method which can technologically actually, so to say, introduced into practice, which would be prognostic and efficient? And science and technology, what they should orient themselves to in this particular question. Honestly speaking, my opinion is as follows. Only direct determination of pH and blood lactate in the blood of the fetus can be relevant and can be informative to assess the further prognosis forecast. And the problems that we have at present and the associations of the leading gynecologists and obstetricians, they refuse from it only because lactate can be taken from the, from the zone, and that is the, kind of the site which does not reflect the probability of brain damage, and it does not give us a true picture 100%. So I hope that in the future we will find new approaches of harvesting blood. It is important where do we take that blood for determining the blood lactate. Thank you. Thank you very much. And by the way, I should say that children of preterm babies could only watch their babies through glass, and only at the end of some long time they could take them really in their hands. And now we would hear about the technology of protecting brain in deeply preterm babies. Thank you very much. Mine is very short communication on the simple technologies. What I am going to talk about does not require a lot of money. They are not expensive. They are simple things, but they are so realistic, so effective for the subsequent development of the infant, even of the least, of the smallest in terms of the body weight. That we have to discuss them. We have gone through different stages of development of neonatology in our country, and at my age, so that's a joke, I have already seen the difference between children whom we have taken care of at the status of deprivation, and those children whom at present we are taking care of. They are different, and they have called my communication open resuscitation, not only because that at present we are now opening a door to the new life, so to say, not only. And I would like to say the following, talking objectivizing this approach, the treatment presence. So this is something which was used by the journal in which we publish data similar to the ones that I'm reporting to you now. And so the presence of the treatment presence, so the presence of the mother as a minimum, and the presence of the parents. This is therapy, nothing else. They are taking care of, and they are just rescuing their baby. So one of these days, I read this publication, and I think that you all will be interesting to read it. You know, the main idea of the open resuscitation is 8 principles were published, 8 principles of patient-oriented, of the family-oriented care of a newborn. And, you know, so the newborn should take care of the newborn, so to say. We keep saying that there are no trifle things in this thing. This global work, you know, these medicines, all this hardware, the respiratory support, they are very important. However, we have to also, first of all, ensure that parents have access 24 hours a day, psychological support to the parents themselves, and also, of course, anesthesia and also effect of the environment, postural support and postural skin to skin, support of the skin to skin. So these are things which are used very actively by our colleagues from abroad. When you see just yet another child, another infant with low body weight, so you see that after the birth, the child will go through the same postnatal algorithm of development of the brain. And it will go to the point when he will already become term baby, and he will continue his development. But it is important to know what will be the conditions for that. As for the prenatal, then everything is okay. We know the conditions, and everything is there for the child to develop to a normal functioning person. However, later we have to understand that there are different aggressive things such as light, pain, and all the other things, how that will influence the development of the brain. We have to reduce the aggression. So neonatologists keep saying that, you know, the ones who are taking care of the smallest in weight babies. And in the context of this scheme of development of the brain, I'd like to say that we have to take care of the babies, but we have to do it in the developing manner, because, you know, the developing care, the care which would be aiming at development. So it has already been there in the world for many, many, many years. Many articles have been published. Many different information bulletins have been published for the parents. So that, and what is a developing care? It is nothing else but just a complex of different simple things. And all of those are aimed to reduce the aggression, to defend the infant from the aggression. And one of the important things is the formation of the affection of the parents to their baby. So we have to leave them together. They should stay together for as long as they can, as you can afford, and that would improve the development of the brain. And we will also use milk, for instance, as prophylaxis. And these are just different, references to different sites. And that's a very interesting 2004 in the journal Pediatrics. This is very interesting study which was published. You know, this efficiency of the individual program of taking care and estimating the development status of the newborns in talking about the nervous system. One group, so you can see 2 groups. In one group, they were given this developing care, and the other group did not have it. Again, the presence of the mother, the breast milk, the things are quite easy. No noise. Please be gentle with the kid, particularly in the first 72 hours, using MRI. These babies in the group with the developing care, we see beta cortical links and also the connections between the hemispheres. And at the age of 8, they study better. They don't have psychiatric problems, and they can learn foreign languages better and easier. And there is another point. Who is the chief? Who can help that small infant to get adapted to the life in the world? And in the psychology, there is such a term, the relevant adult for a baby. And first of all, that kind of adult will determine the development of the child, his visual contact, his interaction with the ones who are near to him. And this should be mother or a parent, I would say, someone who is very close to the infant. And the child has to see the face. Sometimes, you can see that children have different pictures given or different, films but they want to see the face of a near and dear person. So this is not a replacement, or I would say it is the incorrect replacement. So, well, you can replace the adult instead of mother, for instance, if she cannot stay with him, with that baby. And the baby, of course, will get used to the person who will be longer staying with him. And that could be a nurse, a physician. And, the baby is going to kind of when he loses the contact and that particular relevant adult, he actually will think of that person and feel sorry, so to say, about not seeing him, but the mother will still be there, and she will always be there. And you know that this is, well, I'm citing here a presentation from the work of a very famous person whose publications I follow and like them very much and find them very, very useful. Particularly, popular model in the interaction of parents and medical professionals, how this can be done. For instance, the comments that the parents come with in response to this model of interaction, for instance, the parent says that I'd like to feel myself a parent. I'm waiting for the invitation to come up to the child. A more objective model, I would say, an improved model is when you have kind of well-weighted relationships between the parents and the medical professionals. But the parent is still functionally weak, and this is the model that we have realized in our practice. And when we are talking about the open resuscitation, it is the parent actually gets a very high position there because we have to take his advice, and he will be present with us when we do visits in the morning, for instance, or any other time of the day. So the parent is part of our team, and he knows how to take care of the child. Take care of the child, give him something that the baby needs at this time. The parents can sing songs or pray or verses. But there should be someone near the baby who will take him company. Well, I went through that evolution myself. I thought at the very beginning that this is absolutely not relevant, that the parents are just a hindrance. But now we know that they are absolutely necessary. They are relevant. They are very vital in this battle for survival of their baby. And we try to kind of, indeed prove on the basis of the evidence-based medicine that it is important. Well, everyone would say that, of course, the participation of the parents becomes more active. And the family-oriented care, for instance, this is something that we have to advocate because, for instance, it is difficult to say that this kind of taking care will actually influence the outcome, the final outcome. And there are different factors, by the way. Some of them, even in the presence of the parents, in open resuscitation can be dangerous. I just wanted to show different studies. In 2019, for instance, published was that, systematic review. And there are very strong points in favor of the open resuscitation. Presence of the parents is good for the satisfaction. And this is something which would improve the outcome. And the babies in this situation will be, allowed to leave the resuscitation unit. And for instance, if for the first 30 days the mother takes care of the baby grows better. And if, for instance, a nurse is taking care of the child the first 30 days, so that, of course, will influence the outcome. He will grow worse than he would have done in the presence of his mother. So this is a citation from this very important work done by the famous specialist. And one more meta-analysis. 15 regional publications are the basis for it. Also, again, in favor of the family-oriented care. And the weight will grow better. And, the parents are well, they do love to be close to their baby, and of course, their presence is only useful. And this is the kangaroo. Indeed, this method is absolutely obvious, is very simple, but this is something which should be done because this is something which cannot spoil anything. Please pay attention to the twins. The quality of the photo is not very good. And so they have already grown to the age of 8. They are 8 years old at present. And this is when they were quite small. And it was 900 grams. That was the weight that they were born with. And, and that was very difficult. And the mother, did everything possible for helping the kids. And that was the kangaroo successful case, and thanks God, no damage of the brain happened in these two twins. And indeed, it was shown already that children in this situation will grow better. And here compared preterm and term babies, and some preterm which were staying with the mother, and those preterm which were taken care of by the nurse. And you can see the contact skin to skin would improve and accelerate the maturation of the brain in the preterm babies. So you see that a control group, the one which did not have the kangaroo type of care, was different.
This infant had a pulmonary dysplasia. His body mass was below kilo. He received a long respiratory support, oxygen, and only the mother, the person who overcame all these difficulties. Now he is being prepared to get released at the age of 4 months. Now she taught him to suck her breast. Look the way he is doing it. So really, breastfeeding has great opportunities to improve the final result, and we support the opportunity to feed the child with the breast milk. It is difficult. Sometimes women has had this symptom of hospitalism, and sometimes the milk disappeared. So mother breastfeeding is connected with a lot of problems, as usual. Now they write a lot about breastfeeding, but it is important not only to breastfeed, but to put a drop into the mouth. We do it through the probe, and the kids for a long time do not know how to suck. Now a lot of attention is paid to it in foreign countries. If we put milk into the mouth, that will improve the outcome in premature babies. This is a very interesting paper about intranasal breastfeeding. Now they write more and more that breast milk has special fibers that if we introduce some drops of milk through nose, or feed through nose, improves outcomes because milk cells work as stem cells, and children have fewer deficiencies. Now I took this slide from the lecture of our Estonian colleagues. They said that we try to make our resuscitation rooms like this. But then we understood that we need the right side pictures. So that's what we saw in Sweden, in Germany. That's how was it arranged in other countries. This is a family-oriented ward when resuscitation help, intensive care to a severe child, when everything is done in the presence of the mother. The mother lives here. She doesn't come for 2-3 hours. She lives here. The mother and the father may live. In Sweden, it is obligatory that the father should have a maternity leave and spend some time in the intensive care unit. So this study was about the development of parents. They took 70 couples that lived together and 70 couples that lived separately. It turned out that there was not much difference as to quality of the care. Both variants were quite normal. Nevertheless, these technologies are unachievable for us so far. They are a bit fantastic to us, but we will come to it. I took these slides from different foreign lectures. This is kind of a model that we need to strive for, the mother, the father, and the child. And everything should be home-like. Kinder Klindermans is from Austria, from a large hospital where they care for take care of the kids with small body mass, and they have the best results in the world. And she shared the internal protocol of stimulating effect depending on the gestation period. In order to build it, it is important to form the brain correctly. This is just a developing method. They have a very interesting approach dependent on the period of gestation, but I won't dwell on it. But everything started there of assessing the functions, how mature the functions are. In one of the recommendations, depending on the system, whether it is hearing or sight or anything, starting from 22 months of gestation, they should create the medium when the child can take his fingers and put them into the mouth so that the child could touch himself. And through this tangibility, the brain will develop better. This is the case of 18 months of oxygen at home. This is one of the few cases where we could organize. Now this child is 7. The mother was put into the intensive care, and she lived there. It is only with her care that we managed to compensate all hypoxemic crises. Here you see how she is in the kangaroo position, and she spends for 6 and 8 hours together with the child. And here you see his elder sister, and the child was often anxious, and they took all the measures to calm him down. This is a family-oriented approach to create conditions that are maximally comfortable for the child. So today, the child goes to the normal kindergarten and is ready to go to school. He has some problems, but they are not very noticeable. These are the problems, some psychological problem. He has hypermobility, yet he has good abilities for languages. He speaks English, he speaks Russian very well, and he learns English quite successfully. So I think this mother made a miracle, and we allowed her to be together, and that's why this is our small miracle. And I'm ready to answer your questions. Thank you for your attention. If there are no questions, let us pass over to the next presentation. So the next presentation was made by several authors, methods of assessing brain functions in premature children. Dear colleagues, I am representing the Department of Neonatology of Hospital number 67. Our perinatal center started its work in 2022. The average number of patients increased to 53 children a day in December 2023. So we made courses of hypothermia for 4 children, and premature children make up 95–100% of patients of our department. Every day, 2 or 3 patients require monitoring of brain functions. So EEG monitoring was made in 67 cases throughout the year. My presentation is devoted to the very important topic. So we're quite successful in prenatal medicine, but we witness the growth of neurological disability of children. That's why early diagnostics of perinatal disorders of the nervous system acquire a special importance. Various methods are used to assess the brain functions, and each of these methods has its own diagnostic characteristics. They are based on different indicators, but in prenatology we know we use quite a limited number of methods, and it is a low infrared infractoscopy, methods of electrical activity. These methods, they have their own tasks and their informative qualities. What should be an ideal monitoring in our case? Of course, it should be non-invasive. It should provide opportunities for interpretation by clinicists. There should be a possibility of lengthy monitoring. It should have a prognostic indication. And so the first method is close to infrared spectroscopy. Here you see the main indicators. It uses a special technical method. The division of photodiodes is used to register signals from the brain, not mixed with the signals from extracerebral fibers. Then the saturation of fibers is assessed depending on the use of oxygen in the fibers. So here you see a balance between delivery and consumption of oxygen calculated in accordance with the following formula. So the diagnostic possibilities of the method is to assess oxygenation in the area of sensus disposition. In case of insufficient delivery, the extraction of oxygen is increasing from the supplied blood. So its content is reduced in the veins. So this is the description of the method, which shows us the consumption, the level of consumption of oxygen. And it reflects either the reduced consumption of oxygen by the brain or increase of the delivery of oxygen to the brain. The use of this method is good in different states. In normal children, have been also included in the studies, and they were compared with the premature children situations. So this method, of course, has some limitations, and from the point of view of organization, because here practical doctors and healthcare professionals should participate in overcoming these barriers. Then there are, here you see amplitude integrated EEG. It is a screening method. And here we have, we can make a non-expert assessment of the functional state of the central nervous system. So here you see the way this method is used, the indicators of the method, and the amplitude of the variability of the brain function is assessed. The amplitudes are being measured and the difference between them. The limitation, there are some limitations in the method. The integral assessment of the functional state of the CNS does not allow to assess focal phenomena. And we may lose some information about the frequency indicators. The system of assessment of the maturity is quite simple, but we cannot differentiate the achronia and the formation of the bioelectrical activity. We can assess the efficacy of the administered drugs. That depends on the time we have. That's why the visible simplicity of the method can lead to some erroneous conclusions, especially if we have children with an extremely low mass, and they can discredit the method. What are the indications for EEG monitoring? In the first hours of the day, it is made to see whether there is hypothermal determinia. So we make it in case the labor, the delivery was difficult. Since it is a screening method, it may require some multi-channel EEG. The limitations are connected with the low number of channels, and that's why some convulsions can be missed. And there might be hypodiagnostics of convulsions. This slide shows video registration that increases the level of interpretation of the method. So here I show the up-to-date possibilities of the machine software supply, and that may create an opinion that so anyone can do it, but this is not true. Doctors are to be specially trained to use these methods. In case of long convulsive registration, we can use this method and assess it quite correctly. This is an example of the erroneous automatic interpretation. You see this part that was erroneously assessed is shown in red. And you can see that really the effect of the convulsions was not registered properly, and we didn't receive the result that we are supposed to result. And that led to the erroneous interpretation of this pathological pattern. There are some organizational requirements for EEG monitoring. First of all, we need to have relevant monitors. It is necessary to train doctors such as reanimatologists, anesthesiologists, neonatologists to use this machine, because most of them do not have theoretical knowledge and practical training.
And indeed, the data are frequently misinterpreted. And this is the multi-channel electroencephalography in the mode of the monitoring of the video, EEG, and in neonatology, and also in children of the early age. And there are different possibilities that we are using at our disposal. And according to the international experience, the main indication here is the differential diagnosis of the paroxysmal events. We have to identify whether or not, the different kind of convulsions can happen in newborns, and the electroencephalography is something which can help us in this, in the early ontogenesis. And this is bioelectrical activity of newborns in ontogenesis is something which is genetically predetermined. There are different types of pathological changes in and diagnostic possibilities of multi-channel neonatal EEG. And you can see different possibilities. Negative symptoms, and that is the absence of the inherent, condition of the baby, and also different other things. We have to understand that this method is absolutely nosological. It is not specific. As for the organization requirements, they require not only having different equipment units, but also we have to have the nurses, doctors, and also they have to have special training on the neurophysiological investigation in neonatology patients. And of course, the world experience of using functional method for assessment of CNS in the conditions of the resuscitation unit, in the context of the resuscitation unit, includes different studies, and they have been mentioned in the table. So multimodal monitoring, it is absolutely useful, and it is going to become even more useful because we can monitor several physiological parameters at the same time with the aim of ensuring possibility of their parallel interpretation, improving different critical situations, including those which can be a result of the therapy. Also, there is an example of the multimodal approach, which actually combines the different types of studies, such as NIRS, for instance, and pulse oximetry, and heart rate, and also temperature in the real time. And this is absolutely useful, talking about these kids. So an example of multimodal approach which combines these possibilities, pulse oximetry and data about the heart rate in real time. So this is something which is absolutely useful. We cannot exaggerate and overestimate to say their usefulness. And particularly important is that there are prospects of expanding the use of neurophysiological methods in the boards of newborns within the framework of the multimodal monitoring in the resuscitation unit. But we have to train specialists, also neonatologists and resuscitation specialists. We have to introduce the software for centralized access so that we can interpret the results of the multimodal monitoring. Introduction of the multimodal monitoring on the basis of the artificial intelligence will give us a possibility to assess the general status of the infant. And here I'm showing the multimodal monitoring in the intensive care unit. And these figures this sketch shows the way different units which are controlling different functions can be combined. And of course, protection of the brain is a Brazilian program which actually has united almost all the hospitals of that country. And it is absolutely important precedent. And you know that there is a remotely seated team which would actually process all the data and make all the forecasts. So by saying so, I'd like to say that it is absolutely necessary to introduce into the normative and legal base of the organization of the services of a hospital. And of course, the fact that we have to have the modern equipment of different kinds, this is, of course, a fact. We have to improve the algorithm of identifying the convulsions, and so that we can determine the patterns in which we can help the child. And artificial intelligence also has the niche for being used in this situation. And of course, we also have to have a system of training for neonatal specialists at the level of the laboratory, EEG specialists and others. And I thank you for your kind attention. Thank you very much. We have time only for one question only. Thank you very much for your presentation. How do we relate what you have said with those things that we have heard already, starting from which age of newborns, of preterm, we can use each of the methods that you have shown, and also multimodal approach, from which age? Very good question. Thank you very much. You know that all these methods, they do have an advantage, and the advantage is as follows. They can be used from the first hours of life of the kids, and there are many studies which show how the near-infrared techniques can be used, and we do this from the moment when we have children, when we place them into the resuscitation unit, and we do the computer-integrated encephalogrammy from the first hour of life. If this is a newborn at 25 weeks of gestation age, well, there should be some traumatic dangers when you attach a sensor, or can be taken careful. Well, of course, there are some limitations because the sensors, the meters, they may cause some heating, some warming up. And so they can be used, but we have to be supervising this situation. We have to control this situation every minute. Thank you. Thank you very much. Thank you. The next presentation will be given on the cerebral oximetry in the assessment of the autoregulation of the brain-blood circulation in preterm newborns. Thank you. Good afternoon, good morning, dear colleagues. Indeed, I'm going to speak of the use of the cerebral oximetry to assess the brain-blood circulation. In 1937, Danish scientist Michael Fox was the first to mention this, and he studied it using cats. The reaction, actually, he was trying to determine of the arteries to any kind of exposure. and directly under microscope just followed those arteries. And he created the artificial hemorrhage, or for instance, or some other situations, and he noticed that with the growing hypotension, the arteries get wider. And if you have a look at this dependence, so to relation, brain blood circulation and arterial pressure, so you can see the two sinusoids, and the middle of this graph is normal autoregulation. The brain blood circulation stays stable even with the pressure variations. Even when the arterial pressure goes up, so the arteries will get narrower, and this is going to be not at the entire length of the period of the change in the arterial pressure. And if the arterial pressure figure will continue growing, for instance, then the vessels of the brain will stop withstanding this tension, and they would start passively expanding under the effect of this arterial pressure, and vice versa. If, for instance, arterial pressure will go down, then the vessels of the brain are in such a wide status, this actually will happen without any tone. They would stay without tonus, and they actually, you just shouldn't miss the point when the blood circulation actually stops. And this is something that gives us two ultimate points, the autoregulation upper and lower, and the middle of this graph will be believed to be, to be normal. And this distance between two limits will be a corridor of safety. So we are talking of the optimal pressure, and our main task of every clinician to determine individual values of the optimal arterial pressure in a child, in a baby. And in 6 out of 9 studies where the patients had the changes in the optimal from the optimal arterial pressure, and that actually was detrimental. It was that was the case among newborns and fetus. So you can see that the fetus is more or less in the context of the stable conditions, and autoregulation does not have all that importance, so to say. And as for the stability of the blood circulation, so we understand that hemodynamics can actually be changing a lot, and due to this, the cerebral perfusion pressure will also suffer. The autoregulation is ensured, the very movement of the vessels is taken care of by the smooth muscle cells. And they actually appear in the vessels on day 25. And from week 36, autoregulation starts actively functioning. And that autoregulation will actually be attacked by many factors, such as the gestation age, weight at birth, the level of glucose, and also different other factors, such as the condition that the mother is in, low value of the glucose, and the high value according to the scales of the outcomes. It is absolutely important that we understand that there are no limits of the arterial pressure which will truly determine the normal perfusion of the brain. The perfusion, these values will change depending on the clinical conditions of the patient. Even at normal arterial pressure, still, the perfusion can suffer of different organs and targets. It is important to support optimal pressure, and we have to orient ourselves to the optimal, but not normal arterial pressure, because norm can be different in different individuals. And that is why we have an example which is shown here. Well, the study by Dempsey in 2009, there have been many studies. I'm showing just one of them as an example. So the authors followed and saw very good outcomes in newborns with hypertension. And they continuously determined the perfusion of the internal organs, and they have come to the conclusion that if adequate perfusion is there, then the arterial pressure is not all that important, and the outcomes will stay the same. How do we assess the perfusion of the brain? We do this with cerebral oximetry, and the previous speaker mentioned already that this is the way the cerebral oximeter looks, and this is the way the sensor looks and meter. And you can see two photo receivers, and those are the sensors. So the sensors are located at the frontal part of the head of the newborn. And the principle of cerebral oximetry is based on the near-infrared spectroscopy. And this is just a reminder for you that the visible light is part of the electromagnetic radiation. It is quite complex. White color consists of many colors, as you all know, red, yellow, green, and so on. And this part, the red and infrared, we are interested in. So it is near-infrared spectroscopy from 700 to 1,000 nanometers, the wavelengths. And if you enter a dark room and switch on the light, you would see that your hand will actually look red. Well, the fact is that white color only partially passed through our hand. It's not green, not violet, but red. The red one passes through. And that tells us that our biological tissues are quite selective, and they selectively will let the colors go. And the photochromes, or in simple, photochromes are oxyhemoglobin, or hemoglobin, let us agree on that. And depending on the saturation with oxygen of that hemoglobin, the intensity of that color going through our biological tissues will be different. And this is the principle for the NIRS method, near-infrared spectroscopy. And so you can see there is a source of light, not necessarily two sources. We have two sources here, and two photo receivers, and the color will go through the through all the through all the barriers, and will get to the target and to the photo receiver. And the photo receiver will then analyze actually what kind of color was issued and what kind of color got to the target. And talking about the introduction into the brain tissue, it is approximately 55 to 65. And the limitation of this method is in the following. We are talking about oxygenation of the entire head. So it will depend on the site of the head. And the veins of the brain actually take care of 75% of all vessels of the head. And that is why the result of the oximetry will be true of the oxygenation of the venous blood. It should not be 100%. And as for the norm for the newborns in oxygenation of the head is 55%. And it's not only near-infrared spectroscopy, but there are some other methods to measure autoregulation. However, all of them are invasive, apart from Dopplerometry. So you have to submerge certain sensor into the substance of the brain. And of course, we cannot allow ourselves doing this with the newborns. And So the advantage of the NIRS method is in the fact that it is non-invasive. It is not invasive. And how the oximetry and autoregulation work together, so to say. So you see the cerebral oximetry, which will depend, and the blood and the brain blood circulation, but they will depend on arterial pressure. The autoregulation should smoothen out the arterial pressure. And these are two graphs. The right-hand side one, it is left for you. So dependence of the arterial pressure on oximetry. And different values of the arterial pressure will correspond to different values of the brain circulation. And we calculate the index of correlation, and it is close to zero, no correlation whatsoever. Second case, when autoregulation is disturbed, then different values of arterial pressure will correspond to certain values of the cerebral oximetry. And the index of correlation, 0.9, that's high. So there should not be the case in the normal condition. So here we are having the case of injury of the autoregulation. Thus, if cerebral oximetry depends on arterial pressure, then we are having the case of the disturbed autoregulation. And in such cases, we have to more thoroughly monitor the perfusion of the brain and regulate parameters of hemodynamics. And the protection of the brain of the newborn is one of the priorities in taking care of both preterm and term newborns. And that is why control of arterial pressure is based on the assessment of the brain perfusion. And we have to, of course, do more studies about the perfusion of the brain so that we can decrease any damage. And
first of all, in our department, we make surgeries 2-3 a week. And if the anesthesia lasts over 30 minutes, we agreed that we will connect oximetry sensors to the head. We assess oximetry during the operation. If we see a downward trend, then we assess hemodynamics. Hemodynamics will suffer, and we will start changing our brain support and use different volumes for the improvement oximetry. Also, daily we have 50 patients in our department who require intensive care, and 3 or 4 are in a critical state with polyorganic dysfunction. And in these cases, we connect oximetry sensors and assess the state of the brain for further management of hemodynamics and of this child. So this is a clinical case. Yesterday, we had a child, 473 grams, 24 weeks of gestation, 5th day of life. We see a reduction of oximetry, reduction of perfusion of soft tissues, reduced diuresis, pressure is suffering, and oxygenation is about 50%. It's a low indicator. So we start the therapy of this child, entropic support, and for 2 hours we managed to stabilize the child, and we see the upward trend of cerebral oximetry. So we achieved it. 77 indicator of 77 satisfies us pretty well. So here we stop in increasing our help and just follow up this newly born. The second clinical case, the child of 32 years, 2 kilograms of weight, 25th day of life, epistatus. It we decided to use thiopental. This is the moment before thiopental, and this is the moment of introduction of administration. And you see this fence has become much smoother. It is not quite clear why this fence behaved like this, but it is either some limited consumption of the brain, of oxygen by the brain, and we see its increase in the venous blood, or vice versa, it is a higher consumption of oxygen during convulsions, and we see these reductions. So this question is to be studied further. But the most interesting thing is that really the situation has smoothed out. Thank you very much. Thank you for your attention. Thank you very much. How does anesthesia affect the premature infants compared with other newlyborns, the indicators of pressure, stability? Anesthesia affects premature children. Sometimes our children will require inotropic support. Hemodynamics will reduce. It happens much more frequently than in adults. Preterm baby, we very frequently see the distortion of hemodynamics. I will help a little bit. Yes, in anesthesia, especially very premature infants, they usually are operated when they have some acute situation, the septic condition. So usually the child goes to the operation with poor hemodynamics. Those who have grown and we operate on retinopathy without any invasive interference, they maintain their hemodynamics with great difficulty, although they have already matured somehow. Yes, it's quite expected. Now Lyudmila Leonidovna is going to make the next presentation. She will speak about the brain maturation as a fundamental factor in immune neurovascular interactions in stroke. Меня попросили,
So the postnatal brain maturation stage and the unique pace of individual cell type development in the central nervous system at the time of strokes leads to inflammatory signatures. Thus, it is of fundamental importance to consider targeting pathophysiological pathways in maturation-specific ways to preserve brain function and promote repair of the developing brain after stroke. So we'll try to talk about predisposing and modulatory factors that determine the extent of maturation-dependent ischemic brain injury and inflammatory and molecular patterns related to immune neurovascular interactions. If we talk about development of the human brain, I have to say that it is a precisely orchestrated process that requires synchronization between maturation of CNS barriers and cells within the brain parenchyma. So shortly, just to remind you, in humans, brain development commences when neuroepithelial cells of the ectoderm give rise to the neural plate and the closure of the tube that initiates the formation of CNS in gestational week 3, then followed by separation of the CNS from the periphery to the brain vasculature by gestational week 5, and subsequent formation of choroid plexus around gestational week 7 and most of meningeal structures at gestational week 12. If we look at tight junction proteins, which are the structural foundation of CNS barriers, they are detected in fetal brain at gestational week 16. Pyramidal neural cells derive from the proliferating progenitor cells as early as gestational week 5, microglia as early as gestational week 5, whereas astrocytes appear later by gestational week 15, as are oligodendrocyte progenitor cells by gestational week 17. And as we know, myelination starts during mid-gestation and continues until late adolescence. If we talk about rodents, we have to say that maturation of the blood-brain barrier is shown to intimately relate to recruitment of endothelial cells and parasites into the brain, a process that commences around embryonic day 11. Permeability of blood-brain barrier endothelial cells is tightly restricted by embryonic day 15 in mice, so prior to astrogliogenesis, which begins closer to birth. The tight junction proteins start to be expressed in embryonic day 15 cerebral vessels in mouse, and by embryonic day 19, the tight junction proteins appear completely differentiated, demonstrating that astrocytes do not contribute to the early induction of tightness of this blood-brain barrier. In contrast to astrocytes, microglia cells have direct effects on vasculogenesis. So what's important? Important thing is that the timing of these developmental cues in relation to maturation of individual cell types, of the neurovascular unit is critical in influencing the pathophysiology of cerebral ischemia depending on the stage of brain development. So stroke in the neonatal, perinatal period could manifest acutely or in a delayed form, can be arterial and venous, and present as ischemic and hemorrhagic. If we talk about the incidence of neonatal stroke, it's rather high, 1 per 2,500 births, and we need to say that the overall under 5-year-old mortality rate following ischemic events in infants and children is 43 per 1,000 live births, of which 45% of the deaths occur during the neonatal period. Compared to perinatal arterial ischemic stroke, childhood ischemic stroke has a distinct pathophysiology. The incidence of it is low, 1 to 2 children per 100,000. But we need to say that its recurrence is high, making it one of the top 10 causes of pediatric mortality. And what's interesting, recent cohort studies have reported that childhood stroke is associated with long-term mortality, even 20 years after stroke. And furthermore, age at the time of the insult negatively affects long-term cognitive and motor outcomes and increases the risk of so-called ADHD diseases in older children. And one unique discovered aspect of childhood stroke is that it frequently occurs shortly after viral infection and virus-induced immune-related cerebral arteriopathies. In rats and mice, most brain development occurs after birth, like in humans, yet the developmental growth of individual brain regions is different in rodents and humans, thus making it really difficult to adhere to a single postnatal day as a comprehensive representation of brain development in humans. So there are lots of cross-comparison studies in rodents and humans that have demonstrated that the rodent brain at postnatal day 1 to 5 somehow corresponds to 23-32 weeks of gestation in humans, and thus it is suitable for studies of preterm injury, whereas the rodent brain at postnatal day 7 to 10 corresponds to 36-40 weeks of gestation in humans, thus suitable for studying brain injury close to at term, and brain myelination in rodents is complete between postnatal day 17 to 25, and brain maturation is thought to correspond to that of a toddler. So for quite some time, all data regarding ischemia-related pathology in the neonatal rodent brain was based on the famous HI model in postnatal 7 days rats, which involved either unilateral or bilateral ligation of the common carotid artery, followed by systemic hypoxia of variable length and oxygen deprivation. However, we have to say that this model is more representative of hypoxic ischemic encephalopathy and not focal stroke at all. Lots of different groups of models were developed to examine the pathophysiology of neonatal stroke, for example, by using middle cerebral artery occlusion, the most common type of ischemic stroke, especially in term children. There are lots of models of different durations just to enable injury of different severities. And as I said, comparative studies between newborn, juvenile, and adult rodents subjected to various excited, toxic, and inflammatory conditions further extended our concept that the critical role of maturation stage in influencing stroke pathology. And these models included lots of aspects like intercortical IL-1 beta injections, brain trauma, ischemic models of arterial stroke, and so on. And in addition to examine the role of infection, it's clearly understandable because of SARS-CoV-2 infection. Lots of models were developed in a viral-like manner for viral-like infection in mice, and they demonstrated infection-induced arteriopathies. As we say, not all rodent models can be valid, and nowadays we're usually not only concerned in neuroscience, but for example, we are doing organoid models for studying neonatal oncology, solid tumors, and here we can also use multiple cell type neurovascular unit human organoid models containing different types of cells like endothelial cells, pericytes, astrocytes, oligodendrocytes, microglia, neurons for use in disease modeling, even in perinatal medicine. And so we can evaluate the expression levels of different proteins critical in blood-brain barrier maintenance, basement membrane proteins, tight junction transport proteins, and lots of other proteins as well. We can assess the secretion and effect of inflammatory mediators under different hypoxic conditions. Cerebral ischemia rapidly disrupts brain homeostasis in both the adult and immature brain, and we need to say that these processes are very dependent on the age due to multiple factors. For example, if we take early collateral recruitment after stroke, it differs in infants and adults, and in rodents, the brain vasculature undergoes extensive endothelial proliferation in the postnatal month, as do, for example, the NMDA receptors that undergo changes during brain development. And all these factors together with maturational switch to oxidative phosphorylation during second postnatal week in rodents play a very important role in energy deprivation, the phenomena that extensively studied in neonatal HI models. As for apoptotic pathways, they are more readily activated in neonates compared to adults due to expressed proteins involved in developmental program cell death. If we take a blood-brain barrier, the breakdown is well characterized after adult stroke, whereas there are lots of evidence that suggests that the early postnatal blood-brain barrier is not as permeable as the adult one after an ischemic insult. And what's more, the infiltration of peripheral immune cells into the acutely injured neonatal brain is also limited in neonates. And the choroid plexus has lately been identified as the gate for lymphocyte trafficking and entry to the parenchyma. And in fact, the choroid plexus senses changes in the CSF to alter circulating immune cells as well as recruit different inflammatory cells of myeloid lineage and into the damaged area in different models of CNS injuries. Endothelial cells are very sensitive to oxidative and inflammatory processes. Tight junction proteins can lead to endothelial cell dysfunction and death. Lots of transcriptional analysis of endothelial cells isolated from adults and neonatal rat brains revealed a strikingly different gene regulation pattern among ages, thus highlighting age-specific signaling between adults and neonates in neurovascular immune cells after brain injury. Endothelial cells were recently reported to directly crosstalk with perivascular macrophages and even shift their phenotype to immunoregulatory. As for extracellular matrix and basement membrane, they provide structural support to cells, but also serve as a reservoir of growth factors that finally direct the fine-tune of cellular functions. We all know that type 4 collagens are a major component of basement membranes, and its mutations can cause perinatal cerebral hemorrhage. As for parasite number, it's low in neonatal brain, and there's essentially no information of the role of parasites in the post-ischemic development brain. As for astrocytes, they can maintain blood-brain barrier function via direct physical interactions with brain cells, as well as sustaining the signaling molecules. And what's interesting about injury, astrocyte activation is associated with inflammatory events, just like increased IL-15 production, for example, by astrocytes after neonatal HI has been linked to T and NK cell recruitment and aggravation of brain damage. However, in co-cultures, astrocytes were also shown to have a direct crosstalk with microglia and to induce an anti-inflammatory phenotype. That's another example of multifunctional capabilities of astrocytes during neuroinflammation. And I believe it makes these cells good candidates for maturation-specific therapeutic interventions in different developmental stages. The contribution of inflammatory cascades and immune mediators varies upon the developmental stage. Microglia are the primary immune cells in the brain under normal physiological conditions, and upon injury, activated microglia have been traditionally considered toxic by releasing inflammatory mediators. Yet recent data have demonstrated that their protective role, and board-associated macrophages are another type of resident macrophages that populate choroid plexus and perivascular spaces and express both genes found in resident microglia and bone marrow-derived cells. But still, there are no data yet on the role of board-associated macrophages after ischemic stroke during different brain maturation stages. As for neutrophils, they are well described as first responders to stroke, and release of neutrophil extracellular traps, so-called NETs, netosis, is one of the mechanisms of neutrophil-mediated injury in adult stroke. And while this process is currently under investigation in the post-ischemic neonatal brain, administration of viral mimetic toll-like receptor 3 agonists to juvenile mice rapidly activated neutrophil elastase and net formation, inducing vascular leakage and immune cell recruitment to the cerebral vasculars. And importantly, pharmacological inhibition of neutrophil elastase prevented vascular distortion, revealing a potential novel therapy for arteriopathy-induced strokes in elder children. As for lymphocytes in neonates, they infiltrate post-ischemic brain for even months after injury, suggesting their long-term contribution to the inflammatory response. And what's, I believe, the most interesting thing about lymphocytes is that of regulatory T cells, they can provide indigenous neuroprotection in female mice after neonatal HI, while, for example, Tregs interaction with brain vessels in male neonates after HI induce secondary neurodegeneration due to vascular injury. So the role of lymphocytes in perinatal and childhood stroke is still undefined. The cellular source types and magnitude of produced cytokines and chemokines depends on injury severity, but all of us know that clinically, children with abnormal neurodevelopmental outcome following neonatal encephalopathy have very high peripheral levels of cytokine and chemokines. As for pattern recognition receptors, including TLR receptors, they play a key role across ages in many diseases, including stroke and infections. And these receptors are expressed in multiple cells, so immune cells, and mediate synthesis of inflammatory molecules. That's suggesting that post-ischemic inflammatory patterns in the neonatal brain are stimuli dependent, especially on TLR receptors and their activation. Colorectal blood flow is rather extensive in developing brain, although several strategies are being considered for cerebral palsy and stroke. There are essentially no effective therapies that protect the developing brain through adulthood, and therapeutic approaches made at attenuating effects of cerebral ischemia neonates have proven to be short-lived, demonstrating the need to focus on neural repair after neonatal stroke. So this is an example of therapeutic hypotemia, the only approved treatment for HIE that offers neuroprotection and reduces long-term disability. Its beneficial role is limited, though, to milder cases, and its applicability to neonatal arterial stroke hasn't been clearly demonstrated, but its aim is to delay cell membrane depolarization and attenuate intracellular calcium influx and extracellular glutamate release. So, to modulate the inflammatory pathways, including reducing pro-inflammatory cytokine production and attenuating microglia proliferation. But at the same time, studies in human and in animal models have revealed the need to better understand the rewarming procedures and to limit unwanted adverse effects connected with rewarming procedures. During the past decades, cell-based therapies have provided very encouraging results preventing perinatal brain injuries. And administration of umbilical cord blood cells, for instance, inhibited microglial activation following neonatal HI, as it attenuated reactive gliosis and reduced infiltration of leukocytes to brain parenchyma. Also, mesenchymal stem cells were shown to promote regeneration and reduce gliosis when administered intranasally 10 days after HI. We'll also talk today about mesenchymal cells and cell therapy. So I believe you'll have a chance to know much more than I can tell you. Studies in neonatal HI models show that transplanted cells are short-lived and they become undetectable very soon after administration, but they affect local environment and especially myelination. In children, given the influence of infection-induced immune activation that contributes to arteriopathies and vascular dysfunction-induced stroke, steroid treatments have been utilized, and while administration of steroids could be beneficial for limiting infection-induced arteriopathies, more data is required to show that they can either treat or prevent arteriopathy-induced stroke, so by muting immune response. As a conclusion, well, it's, I believe, no longer disputed that the developmental stage of the brain at the time of stroke, at the stroke onset, plays a key role in injury, and that inflammation is an established hallmark of brain injury in infants and children. However, we need improved understanding of the specific cellular molecular pathways involved in post-ischemic cascades during different stages of brain maturation, because this will help to identify maturation-specific targets and make new variants of therapies for newborns and children. Thank you. Спасибо.
Большое спасибо. Questions, please.
Hi. I just wanted to understand, in neonates, stroke is primarily due to large vessel problem or due to microvessels?
Well, it mostly to microvessels.
Yep. And the therapies which you showed here, those are commonly given at what stage, or it can be given at any stage?
Yes, they can be given at any stage, but if we talk about newborns, so for example, birth asphyxia, we use these treatments just at the beginning, when the baby is born.
And third question, just related to that, by what stage the vasculature is really well developed in the developing brain? Like as close as to what you would get in adults?
In adults. Well, that's a very complicated question because there is lots of literature on this matter. But if we take a medium of the age, so it's about 6 to 8 months of postnatal age.
Okay, thank you.
Еще вопросы, пожалуйста.
Any other questions, please? Questions are invited. If not, then may I ask a question?
But probably you can expand. It is known that in the adult brain, during stroke, stem cells can migrate into the zone and play an important role in the process. In the neonatal brain, there must be much more stem cells, and Alla Lvovna mentioned that they can get to the child through the mother's milk. Anything known on the animal models of neonatal or child stroke of their role and scale of stem cells involvement in the stroke process and recovery?
Well, as far as I know, I don't know any models that studied stem cells in the preterm or term neonatal brains, but stem cells are quite difficult to be detected if we talk about human models. So in animal models, yes, they could be detected, but unfortunately there are not so many studies about it, just to make some obvious comments on your question.
Thank you very much once more. И у нас кофе-брейк на 20 минут. Мы встречаемся в половину первого.
Уважаемые коллеги, давайте продолжим. Пожалуйста, давайте потише, сосредоточимся на работе. Следующий доклад «Нейропротекция при остром повреждении мозговой ткани в эксперименте. Оценка эффективности секретома мезонхимных стромальных клеток». Карагюр Максим Николаевич, Институт регенеративной медицины МГУ имени Ломоносова. Максим Николаевич, пожалуйста, вам слово.
Дорогие коллеги, добрый день. Организатор конференции.
Dear colleagues, the organizers of the conference asked me to speak in English, and I may answer questions in Russian.
First of all, I would like to thank the organizers of the conference for the opportunity to share our results among the clinicians, and I hope that this opportunity and this conference will make the approach that we develop close to clinic. Well, today I would like to continue the narration of Lyudmila Leonidovna and to discuss the opportunities to stimulate neuroprotection after brain injury. And here I concentrate on the acute brain injury, as I believe that it is the main stage in a wide range of pathologies when we have the opportunity to protect neural tissue and to prevent its degradation. Well, brain tissue is very complex, and it's really hard to stimulate its regeneration. So it's much easier to to stimulate its neuroprotection. As I have said, acute brain injury is the initial stage of a wide range of pathologies, among them strokes, traumatic brain injury, and infectious damage, and perinatal asphyxia and asphyxic brain injury as well. And only in Russia there are more than 1.5 million cases per year. Conditions and pathologies which start with an acute brain injury, and some of these conditions are really life-threatened, and some of them lead to death or disability. And Lyudmila Leonidovna has told us about cell therapy, but cell therapy has some restrictions, some limitations, and so we prefer to look for the ways to use cell-free therapy. And so I can affirm that for today there are no registered preparations based on human proteins that will protect the generation of nerve tissue during its acute injury, and which would have a complex neuroprotective and inflammatory and pro-regenerative effect. Well, here is a simplified scheme of the regeneration process of any tissue. An injury starts the regeneration process, and here you can see that it consists of multiple stages, and it involves multiple molecules which change each other, and multiple molecules and multiple cell participants, and modern concepts consider mesenchymal stromal cells as the key regulators of the regenerative process. Why they are so important? They can suppress, they have immunomodulatory effect. They can stimulate survival of indigenous stem cells. They stimulate angiogenesis and neurogenesis, and well, and have many other. And they protect cells from apoptosis. They exert direct anti-apoptotic activity. And that is due to their ability to produce a wide range of factors that stimulate angiogenesis and axon growth and immunomodulatory molecules and matrix proteins and so well. This fact was confirmed in multiple studies and in our study as well. And they also produce a wide range of extracellular vesicles that contain microRNAs, and some literature data affirm that extracellular vesicles are able to penetrate the blood-brain barrier, and so potentially this secretome may exert a neuroprotective activity. Well, to test this, we used a model of intracerebral hemorrhage previously described, and here some blood was drawn from sublingual vein, autologous blood, in rats, and then it was administered into the inner capsule, in the capsule of the brain, which is white matter of brain and consists of a wide range of which contains corticothalamical pathways and corticospinal pathways, and so when we damage it, we can observe a wide range of neurological symptoms. After modeling the intracerebral hemorrhage, some preparations were administered, and the main preparation that we started was MSC secretome, and there was in some rats we administered a control substance that was empty cell culture medium, DMEM, Dulbekos modified Eagles medium high glucose. Well, moreover, there were some groups with positive control where we administered cerebrolizine and a combination of recombinant factors, brain-derived neurotrophic factor, and urokinase plasminogen activator. Well, then they were assessed the survival rate in rats, the neurological impairment, and the lesion volume with the help of MRI. And what we have found that MSC secretome, that in the group of where MSC secretome was administered into the hemorrhage focus, no animals died. While in other groups, some animals died within the range, within the observation range. Well, and moreover, in the group where the secretome was administered, no neurological deficits were observed as well. Green is for visually healthy animals, yellow for those who were slightly affected, severely affected, red, and black for those who died. And that was confirmed by MRI, that MSC secretome administration reduced the volume of brain injury, and that was confirmed also by histological studies. Well, and in our first experiment, it was a proof of concept. We decided to test if MSC secretome reveals its neurological activity, if it's neuroprotective. But we understand that if we try to translate it into clinic, it will be really hard to administer secretome right into the brain tissue. So we test some other administer pathways. For example, intravenously, we administered it intravenously, intranasally, and intrathecal. And to our surprise, we observed that MSC secretome administered intravenously also stimulated the survival of animals, reduced the severity of neurological deficits, and also reduced, statistically significant, reduced the volume of the tissue brain injury. Well, all that was in 5 minutes after brain injury. 5 minutes is too short for clinical translation. So we decided to test if what is the door to treatment time we have to use to use MSC secretome, and when it still retains its neuroprotective activity. Well, and we test 1 hour after modeling ACH, intracerebral hemorrhage, 3 hours, and 6 hours. And we found that only in an hour after all this secretome was administered intravenously. And we found that only after being administered 1 hour after intracerebral hemorrhage, it statistically significant diminished the volume of tissue brain injury. But we decided it was just a single administration intravenously into the tail vein of a rat. Well, we decided to try if we make not only a single administration but several administration, would it help? And surely it worked. Here you can compare a single injection and 4 injections. 1 injection in an hour after modeling the intracerebral hemorrhage, and 4 times first in an hour, and 3 sequent and the other injections were made in every 48 hours after the modeling intracerebral of the ICH. Well, and so this means that MSC secretome contains something that is able to protect brain even after 48 hours post intracerebral hemorrhage. Well, that is why this experiment confirms that we can enlarge the door to treatment time to use MSC secretome. And the logical question is how MSC secretome works when we administer it intravenously. We don't have a complete answer, but according to the literature, some neurotrophins and growth factors that that are parts of the MSC secretome, they can penetrate blood-brain barrier as well as extracellular vesicles do. Moreover, into the site of injury, blood-brain is broke, and so it may help to growth factors and extracellular vesicles to get right into the site of injury. And moreover, we suppose we suppose, a serious anti-inflammatory effect of MSc secretome. And it is confirmed by our in vitro studies, where MSc secretome suppresses the expression of, suppresses the polarization of human blood, peripheral blood monocyte macrophage cells, and suppresses their polarization into inflammatory, pro-inflammatory way. And so they and MSc secretome stimulated their anti-inflammatory polarization. Moreover, MSc secretome exerted direct neuroprotective activity in an in vitro model where human neuroblastoma cells were used in the test of glutamate-induced toxicity. So here are the concluding remarks, and the negative consequences of acute brain injury can be halted and mitigated, and MSc secretome exerts such an effect. MSc secretome retains its neuroprotective activity even when administered intravenously, and it remains active even after 48 hours after intracerebral hemorrhage. And we have found that the main mechanisms of neuroprotective activity of MSc secretome are its direct neuroprotection and its immunomodulatory activity. Well, I would like to underline some points that we have chosen the model of intracerebral hemorrhage because it's universal, and it includes other pathogenetic mechanisms that because it includes such mechanisms like ischemia, toxic activity of blood, neuroinflammation, and so on. And so these the observed results can be, I believe, they can be they can be these results can be used to treat other pathologies such as traumatic brain injury and various kinds of strokes, and as well perinatal asphyxia. Well, and here, basing on these, on the obtained results, we can assume that human MSc secretome is maybe such a promising complex of human proteins that is suitable for treatment of acute brain injuries, and that exerts a complex neuroprotective, anti-inflammatory, and progenerative effect. Thank you for your attention. If you have any questions, I'll go ahead. Thank you.
Thank you very much. I have two short questions. First, you mentioned that you tried also intranasal administration. Was there any effect?
Yes, there was an effect, but intravenous was much more prominent, so we left on this one. And intrathecal showed no effect.
Second question, what was the age of animals during acute brain injury?
There were several experiments. First experiments we conducted on young animals, about 3 to 5 months old, and some experiments we conducted on old animals, 8 to 10 months. And MSc secretome revealed its activity in old animals as well.
Taking into account the topic of our today conference and what we've heard about neonatal and child stroke, might be very interesting to continue your experiments on neonatal and young animals. I expect that the effect might be sufficiently stronger.
Thank you for your recommendation. Yes, we'll think about this and looking for the opportunities to do this. Thank you. Thank you.
And one more question. What do you think of opportunities to start clinical trials? When do you think you're going to do it?
This sounds great, and we would like to start them as fast as possible, but we need to finish the preclinical trials to demonstrate that it's safe before using. My colleagues use MSC to treat other pathologies, for example, male infertility, and a few days ago they obtained the results that MSC being administered locally is safe and has no adverse effects. And we hope that here in being administered intravenously, we hope that if we use it for a short period of time, it will have no adverse effects too.
Thank you very much. Спасибо.
Thank you.
Я с удовольствием представляю наших.
And this is my pleasure. I'll give the floor to our colleagues from the specialized center. Well, the subject of the presentation is changes in lipid energy and molecular genetic peculiarities in neonates with intraventricular hemorrhage. Thank you. Dear Chair, dear colleagues, I'd like to start with thanking for the invitation to participate in this important meeting. Before I start my presentation, I would like to say that the idea of the research which results I am going to demonstrate today belongs to Evgeny Neudakhin, professor, well-known pediatrician and cardiologist. In many of his works, he studied the iatrogenic processes in a child organism in different pathologies and the stress theory for the origination of such processes. And this is our joint work, and that's why changes of the lipid energy and molecular genetic peculiarities of the neonates with the intraventricular hemorrhage. Briefly, let me remind you that there are three major reasons for the intraventricular hemorrhage in preterm babies. First, the immaturity of the germinal matrix and the peculiar features of angiogenesis and neurogenesis. In the germinal matrix, the angiogenesis is accelerated, and for that reason, it contains a lot of immature, broad, fine wall vessels. And the absence of the pericytes and low content of fibronectin in the immature basal planes actually promotes the fragility of the vessels of the germinal matrix, and the cells of the germinative matrix, they are rich in mitochondria and they are quite sensitive to the lack of oxygen, hypoxia. Violation of the cerebral homeostasis and the brain blood circulation in the conditions of hypoxia, the autoregulation is disrupted, and the higher rate of the brain blood circulation and venous venous problems start. And because of that, we have studied the problem. And by the way, I should say that the thrombocytopenia in preterm babies can be caused by infection or immunization, low production of thrombocytes or platelets due to the small size of megakaryocytes, precursors of the platelets, and also violations in the blood coagulation in the preterm neonates with the intraventricular hemorrhage. They are expressed in the not normal levels of the MHO or rather I should say the international normalized ratio, the INR. And also I should say that the mutations of the gene, well, antithrombin 3 and fibrinogen. And the genetic factors, of course, here very important is the coding pro-collagen of the type 4. And also mutations of the gene, they do cause perforation of the basal membrane of the vascular wall, and they are responsible for the blood, for the hemorrhage from the germinative matrix. And the pathogenesis of the intraventricular hemorrhage in neonates has many factors to play here. And the development of this blood, well, this problem actually is due to the combined effect of the vascular intra and extra vasal factors, and it is accompanied with systemic and local pathological changes in the organism. The main trigger here is an increase in the intra-brain internal brain pressure, and it is accompanied with the pronounced stress reaction. The stress reaction is the basis of the iatrogenic problems. And indeed, the notion of a stress and adaptation syndrome, actually the start of that biology concept of the stress was given by Gans-Cellier in 1936. Stress is non-specific response of the organism to any change in the conditions. Adaptation syndrome is a totality of non-specific changes which originate in the organism of man when there are pathogenic irritants are acting. And of course, we have to say that the studies of the peculiar features of the lipid metabolism or exchange and activity of mitochondrial enzymes in neonates with the intraventricular hemorrhage for the characteristics of the adaptation processes in the organism. We have studied 30 children aged 14 days to 2 months of life, 25 to 37 weeks of gestation with intraventricular hemorrhage, 44 healthy children of the first 3 months of life, and 18 healthy newborns of the first 5 days of life. And the diagnosis was established on the basis of neurosonographic examination, computerized and magnetic resonance imaging. Lipid metabolism parameters were determined in the followed children: total cholesterol, triglycerides, low-density lipoproteins, LDL, and high-density lipoproteins, mitochondrial enzymes of peripheral blood lymphocytes, lactate dehydrogenase by a quantitative method modified by Narcissa. And what is the role, actually? The cholesterol and triglycerides, they are particularly important. They ensure the lipid metabolism. And cholesterol is a very important part of the membrane, and it is absolutely necessary. And the products of lipid exchange, they are very important in pathogenesis of most severe conditions of neonates, such as respiratory syndrome, sepsis, and others. The condition, well, the status of the lipid exchange, of course, depends on the body mass at birth. And indeed, all these things are to be taken into account. And indeed, the perinatal period is very important, and here the status of the lipid exchange in neonates depends on the gestation age and mass of the body mass at birth, as I said. And the low production of triglycerides is characteristic of the deeply preterm babies with low and extremely low body mass at health. And indeed, changes in the lipid exchange components in neonates with the intracranial blood hemorrhage, depending on the gestational age. When we tried to see the changes in the indicators of the lipid exchange in neonates with the intraventricular hemorrhage, it is important to see what's happening with the triglycerides. Triglycerides are higher if the the situation is bad with the hemorrhage. For a difficult case, they are very high. And indeed, here, with the purpose of estimating the non-specific reactivity, we have done this study, and the results are shown here. In the normal status, the assessment of the leukocyte index Garkavi in healthy neonates and neonates with the intraventricular hemorrhage looks like this. And so the changes in the indicators of activity of mitochondrial enzymes in neonates with the intraventricular hemorrhage. So the more severe is the case of the situation, the higher are the values for the three indicators which are shown in the first column. One of the structures which can play the role of biomarkers at the early stage of development of the disease is microRNA. And the microRNA is referred to a subspecies of the smaller molecules of RNA, which are united into a separate class of smaller non-coding RNA. And the basic function of this is epigenetic regulation of the gene expression. MicroRNA are considered to be a molecular parameter for determining consequences of the stroke and the subsequent tactic for treatment of the patient. And this is also in oncology as prognostic markers and also as a marker for the early preclinical diagnosis. And for this role, the microRNA, they do have advantages. The molecule is stable. And here I'm showing the list of microRNA, which we have studied during our studies. And by the way, you can see that the RNA 21 is growing in its amount. And you can see that this is a comparison of the level of microRNA in patients with intraventricular blood or hemorrhage and healthy neonates. And so we see that there is a tendency for higher number or greater amount of microRNA 21 and reduction in the level of microRNA 126 in patients with intraventricular hemorrhage compared to healthy neonates. And this is particularly appreciable in assessment of the ratio between the level of microRNA 21 to the level of microRNA 126. So this is a ROC curve, and it is highly sensitive and highly specific. So indicators of a lipid exchange or metabolism in neonates with the intraventricular hemorrhage testify to the fact of the violation of the metabolism of triglycerides, and the high activity of mitochondrial enzymes shows the pronounced, I would say, situation with the energy exchange and high activity of the aerobic and anaerobic glycolysis, which are going on against the background of a metabolic acidosis. Thus, we can say that the stress status of the organism with the hyperadaptation syndrome is accompanied with pro-inflammatory and pro-atherogenic reactions. And besides, according to the results of the genetic study, the changes in the level of microRNA 21 and microRNA 126 in children with intraventricular hemorrhage reflect the transformations in the organism. Thank you. Any questions? Yes, please. Microphone. Please ask your question to the mic. Please ask your question to the mic. What's happening in ischemic lesions or infection caused? So they are specific for other cases as well. This study was done for the intraventricular hemorrhage. And I'm sure that the indicators will also be very specific for other pathologies. Please take the mic, will you? This is very interesting, isn't it? It has to be studied. You haven't yet. Okay. Thank you. Early medical services to neonates with perinatal lesions and the congenital defects of CNS. Welcome. Good morning, dear Chair, dear colleagues. I'm given the task of presenting data on the neuroprotective methods of respiratory therapy and the results of our work. I'd like to start with the statistical data. So 1 billion in the world, 15% of the population, they do have severe defects and these, different problems, which actually limit them very much in the participation of the life of their families. And there are three major reasons which cause that situation: disability, the psychic disorders, also disorders of the nervous system, and the congenital defects. And of course, we have to help our children, and this is particularly important today. So according to the data from the Perinatal Center in the Russian Federation, in the structure of disability, so children at the age of 27 weeks, you can see that here the nervous problems prevail. And so we wanted not only to improve the medical assistance to medical services to children of the first year of life, but also improve the survival and indeed help in every other possible ways. And as for the peculiarities, we have already said that this is something which has to be done as a teamwork, and we have to understand that the multidisciplinary approach is a must. Methods which we are using are, of course, surgical correction, also the drug therapy, drug administration, and also the different non-therapeutic methods. So we use all methods in the same case sometimes. Taking into account the specialization of our center aims at providing services to support the children of this age. And most frequently, we treat patients with the nosologies that I showed in the slide. And so the symptoms shown in this slide are actually the ones that we have to work with every day. I'll start with the neurosurgical pathology, and so I will speak of each a little bit more. So hydrocephalus, this is something which we come across more frequently than anything else. So it can be classified in different ways depending on the parameters. And in the neonate period, we normally deal with the congenital, for instance, Dandy Walker, for instance, and also the spine, hernia, also post-hydrocephalus due to the intraventricular hemorrhage in the preterm babies, also post-infection ones after children had some neuroinfection, and we have to treat them after that. And because of that, they do have problems in the brain. And so about 3 to 1, so this is a proportion of the occlusion rather than other hydrocephalus. So the only method of treatment for progressing hydrocephalus is surgery. And it is either kind of the surgery to deviate the flow of the liquid, the CNF, the spinal fluid. And so these are different types: ventricular peritoneostomy, for instance, and that is a shunt, and ventricular arteriostoma. Of course, there are some points which are worth mentioning because they do complicate our work. because this type of surgery is quite limited due to the composition of the CNF and also its sterility. Sometimes we have very high risk of the infection, and this kind of surgery is not effective in the occlusion type of hydrocephalus. And because of that, we look for different alternatives, and one of them is endoscopic correction of the CNF dynamics. And the purpose of this method of treatment is to do away with the occlusion of the CNF ways, and this has to be done within the given area, and we have to respect it. And of course, it helps us to delay the implantation of the shunting system for a preterm baby, because this is the category of patients which, of course, we have to be very careful about. And of course, in 1/3 of our patients, despite the fact that endoscopically we can decrease the problem, but the progression of the hydrocephalus will continue. And in such situations, we do the ventricular peritoneal shunting and bypassing, and we cannot reach the 100% effect, because we can remove this by using the bi-side, but still we have to do ventricular peritoneal bypassing again. And we gain some time for a child to grow a little bit so that it will be easier to cope with the results of this surgery. I wanted to show you several examples of this surgery. And in this slide, I'm showing a preterm baby, 28 weeks of the gestation age. And you can see the body weight, 1,430 grams. And you can see the occlusion of the sylvian of the brain. And the 3 ventricular cisternostomy was done. And the brain sylvian has been actually treated, I mean the occlusion of that sylvian, and the baby is growing, is developing, and that was quite a good outcome.
Well, an older child of 32 weeks, 840 grams weight. So we see here occlusion. So we made endoscopic correction of liquid dynamics. And now the child goes to the second form of the school. Here is a very interesting case. This case showed us to what extent our hospitals are consistent in their approach. So she was born. There was atresia of the anus. She was transferred to the Filatov Hospital. Our colleagues identified made esophago and gastrostoma. They installed sigma stoma, but hydrocephalus developed, and the child was transferred into our center. And at the age of 1 month, we made an operative treatment. We corrected endoscopically the liquid dynamics. You see, we installed a stent, and since the child had to endure many operations on the chest, on the abdomen, so the bypass operation would have been too hard for her. And endoscopic correction was quite a correct choice, quite a good solution. So afterwards, we returned the child to the Filatov Hospital, where they completed all surgeries, and now the child is developing quite well. This child is Vactor Association. This is spontaneously arising anomaly of development. and boys suffer more frequently. About 1% of children have this pathology. If the specialized surgical treatment is timely and successful, then these children develop quite normally. They do not have any deviations in the physical or mental development. The next group of diseases that we face is arachnoidal cysts. So congenital liquor formations, and arachnoidal shell is splitting. So the frequency is high in boys, higher 2 times in boys than in girls. The localization is very different. It can be located in all, they can be intercerebral and other types of cysts. This is prenatally diagnosed arachnoidal cyst on the 32nd week of pregnancy. So the baby was born on time and was transferred into our center. So MRT showed a huge arachnoidal cyst in the semisphere slot, and that led to the compression of the brain, occlusion. There was a little deformity of the head, and at 2 weeks of life, he underwent a surgical intervention, and so the size of the cyst reduced considerably, and the compression of the brain was removed. So the purpose of surgery in arachnoidal cyst is to connect it with the ventricular system or with basal systems in order to reduce its volume. The next group of diseases is craniosynostosis. They may be syndromal form or non-syndromal form, Apert, Cruzona, and Pfeiffer's. That's what we most often see. The surgical interventions are different here. For diagnostics, apart from physical examination, visual examination, it is necessary to make an MRI with 3D reconstruction, in which we may see various forms of synthesized seams. And these children undergo different reconstructive operations. But operations in craniosynostosis are very traumatic. They are large and invasive. But in some types of craniosynostosis, we may use endoscopy-assisted craniosynostoectomies that are done on children from the age of 2 to 4 months, and that allows to avoid larger and more serious operative interventions in the future. This is an example. The upper slides show CT and MRI. This is the child of 37 weeks of gestation, retarded in vitro, in utero, and here he has hydroencephalus, and we managed to make 2 operations. We removed the seam and removed the occlusion of liquor pathways. We established the way to the ventricular system. Hypertension was removed, and the form of the scalp has changed. And the child was released on the 12th day. Then I would like to show you upper syndrome. Apart from classical symptoms, we see the change of the scalp form. upper also shows syndactylia changes, syndactylia on hands, on legs. Cruzon syndrome is quite frequent, although the population is 1 per 60,000, but we see very many children with this syndrome. Apart from the deformation of the scalp, they are very often combined with hydrocephalus and atresia and narrowing of nasal orifices. So we have to install tracheostoma, or like here, we use these nasal activators or intubation tubes to ensure the breathing activity. After the correction, the structure of the bone tissue changes, and the child does not need these protectors in the future. Here you see the example of the multiple craniosynostosis. The child also could not close his eye slots, and this is a premature child. 31 weeks of gestation, 1 kilo 600 grams. And there we had to take care of him until 3 kilos, when our neurosurgeons were able to make a surgery. And after the first stage of the surgery, you see the form of the scalp has improved, and the eyes began to close, and he could close them independently. Further, he had a development of hydrocephalus, combined disorder. At 5 months, he underwent the bypass, and the next MRI is the age of 6, but at 7, the child went to a secondary school, and he will go to the 3rd form next year. Often we have different forms of spinal dysraphisms, and here we also make surgeries. Sometimes we make them on the first day of life because the disorder of the hernia sac develops. These operations I made with the nervous monitoring. There is always a neurophysiologist in the surgery team. Here we see different brain hernias, and also we see birth traumas. We have intercerebral hemorrhages, and they require an early neurophysiological participation to minimize the neurological defects. Here you see hematoma with epidural hematoma that were removed surgically. So the birth trauma, here you see the fracture. So we removed the bone defect, and the child stays in the hospital for 10, 14 days. So I have spoken about the operative treatment. We also use non-operative therapies, drug and non-drug therapies, with perinatal disorders. I would like to say that the importance of the multidisciplinary assessment of the patient's potential. It is a complex approach to setting up the rehabilitation program. Urogenic disorders affect all the life ensuring systems, and that's why it is very important. I would like to say that impossibility to use regulated programs of rehabilitation and accepted programs because there are some counterindications for our patients. The duration of rehabilitation always requires, is always determined by the doctor's decision. So these patients cannot undergo physiotherapy, and we need to preserve the protective way of caring for our patients. As to the non-drug treatment includes all kind of physical exercise, including respiratory gymnastics and the massaging in different variants adapted to the state of the patient. When making a rehabilitation plan, it is very important to foresee the prognostic levels of the outcome in order to restore the functions and to readapt the patient with the help of various ways of treatment. Here we often use tracheostoma, gastrostoma installation in these patients. And of course, the establishment of the prognostic rehabilitation probability allows us to provide an optimal help to the small patient. And of course, a complex, timely, multidisciplinary and individual character of our approach and the intention and non-standard approach allow us to improve the quality of life and reduce the possibility of disability. Thank you.
Neuroprotective methods. So to the neonates, neuroprotective methods of respiratory therapy at the stage of the delivery hall and department of resuscitation. Dr. Abalova-Popov, Dr. Popov will speak. Dear colleagues, the entire conference is dedicated to brain, but I'm going to speak about the lungs. However, everything will boil down to the brain. Okay, globally, if we look at our planet, so the population of the world goes up and by 2023, we have already passed the point of 8 billion, citizens, residents of the planet. And indeed, you know that on the planet, we have about 140 million children born. However, if we look at the birth rate here in Russia, for instance, starting from 2016, it goes down all this time. And today, in the 2023, we have about 1,260,000 live births. And of course, every child who is coming to this world, to this best of the worlds, is absolutely precious for all of us. And naturally, we have to struggle for every child. And talking about the neonatal stage, it is that particular stage is very vulnerable from the point of view of the survival. In 2017, all over the world, by 1,000 live births, on the average, 18 deaths we had reported. And this is the map of the pediatric, of the neonate death. And you see the number of deaths per 1,000 live births is growing. In 2015, during the first month of life, about 2.5 million children died. That is 6,700 cases of death. This is a little bit more. It is about 47% in the age bracket of up to 7 years compared to 1990s last century. And what is the reason for that? First of all, the preterm labor, delivery, asphyxia during the birth, during the delivery. These are the main reasons. And of course, in all such cases, children cannot do without respiratory support at birth. Talking about term babies, and of course, it is particularly difficult if the patient is born in the status of asphyxia, and the woman has been carrying the baby for 9 months, and then a catastrophe happens, and it influences not only the life of that child, but also two particularly relevant and very important for that child people, his parents, and also a number of many other people who live here and depend on that child. So several millions of children die of asphyxia, and we know that there are methods which actually can help us go out of this situation in majority of cases. And if we behave properly in the delivery hall, then we can, of course, save at least 250,000, save them, and they would stay on this planet. And see, 23% of all cases of deaths is asphyxia at birth. And of course, this asphyxia at birth is the main reason for neonatal death in countries which have low or average income rate. So this is also a cause of the long-term neurological problems. Another global problem, the preterm delivery, 7 to 12%. In Russia, this percentage is 5 to 7%, 12 to 17% of the preterm delivery in major megapolises such as New York, Tokyo, Mexico City. And as a result, 92% of the extremely preterm babies born at the age of less than 27 weeks of gestation age in Australia or New Zealand, and they do require a form of the artificial ventilation. So these are absolutely golden hours, golden minutes. They would determine the future of many of our patients, and in many such ventilation may already be required in the delivery hall. Although the respiratory support is absolutely important for survival, the artificial ventilation is a zone of a high risk. And actually, it may lead in terms of the damage of the brain in preterm babies, taking into account the fact that extremely preterm patients, they indeed are vulnerable from the point of view of the brain damage, and any intervention which may happen during the perinatal stage, including artificial ventilation, has to be absolutely optimized. Contrary to the Department of the Intensive Therapy and ICU and perinatal centers, the delivery hall is different. We do not concentrate high technologies there. We do not have the artificial ventilation equipment of a serious, so to say, expert level. And as a consequence, about 75% of children who get that need artificial ventilation, they would actually get it using different, manual methods, and then the doctor will be actually controlling the respiratory rate in that child, and sometimes that volume may be excessive to such an extent that it can actually increase the intrapulmonary pressure, and that would actually make higher the risk of the brain injury, just due to the fact that the basin of the blood in the vessels of the brain. So, the more preterm the baby is, and we have heard about this more than once during today's program, the higher is the risk of the intracranial hemorrhage or some other problems, very serious ones. Talking of the ventilation induced, that is depending on ventilation brain injury. Well, basically, the first way to the damage of the brain is initiation of the lung inflammatory cascade. Since we, for instance, supply the too much air, And actually, this leads to the overloading, and then we would see that penetration through blood-brain barrier, and this may cause the inflammatory reaction, which is enough for causing the inflammatory stress. And there is another way, which is due to the excessive broadening of alveolus, actually increase of the pulmonary resistance, which can lead to the hypoxia development as well. And in combination with the immature autoregulation and penetration through the blood-brain barrier, this dynamic situation can cause the alternative supply to the brain, and this leads to extravasation, and this is happening when you have an excessive respiratory volume, so the portion of the gas which gets into the lung during one inhale. Talking of the ventilation with the high respiratory volumes, we have done many studies ourselves, and we also have read about many studies done by other colleagues from different countries. And one of them showed that when even short-term artificial ventilation with a great respiratory volume, 15 per kilo, actually led to problems with the parenchyma and development of the serious neurological problems. Somewhere in 2017, 2018, we decided to start from the physiology of the respiration, and we have tried to change a little bit the therapy starting from the first early minutes of the life. So by doing so, the choice of this method of the high frequency rate of ventilation for the delivery hole for the immature lungs was based on the following physiological properties of the immature lungs, because they have very short period of time for the inhale and quite high respiratory rate, so that the patient may get enough gas per minute. We assumed then that the high-frequency ventilation with positive pressure can lead to a more positive pressure, and as a rule, it can lead to cardiorespiratory adaptation and improvement of the outcome. A baby, an infant with the severe RDS syndrome, before we introduce surfactant up to, before that, the patient, 1 kilo body weight, with severe RDS, distress syndrome, he would have 2 to 4 milliliters per kilo. And these 2 milliliters actually should be enough for a child to breathe and live. We have compared two types of the respiratory support in neonates and with severe deficit of surfactant who required intubation of trachea. And so we have developed an experimental model, and we have first tested our assumptions using the experimental model. This is the mannequin, which, according to its sizes, is similar to that of a baby, 800-gram weight. And so we have used the Ambu sac and a metronome, and experimental model was used. And these are the results. If I am successful in switching on the video, I'll show what will happen. Probably you have recognized the hands of Anna Lvovna. So she is a very experienced and expert. And you see about 60 inhalations are given to this mannequin, and see at this respiratory rate, 60, the respiratory volume is 10 milliliters multiplied by 0.8 body weight, so about 18 milliliters per kilo. When we tried, respectively, to do this kind of high-frequency ventilation, on the average about 240, and this is, for such a patient, it is high-frequency ventilation. Well, you know, when the ventilation is actually increased by a factor of 4 compared to the normal, so just have a look at this respiratory volume. In high frequency ventilation in the experiment, and you see that the respiratory volume is already 3 milliliters multiplied by 0.8, about 4 per kilo. So with this kind of ventilation, we can limit the respiratory exchange and support the gas exchange in a child during the first minutes of the life of the child. Our study was randomized. So before the delivery, we have actually took anonymously, so to say, the envelope from this box. And so 5 patients needed surfactant, and they were in a special group. And then we followed the children. So respiratory adaptation was quite adequate in the delivery hall. And after that, the patients reached the target saturation. And after that, we also evaluated all the parameters of the respiration and all the other things. Of course, we can say that this is a very good hardware, so we can use it in the delivery hall and use it for this very good purpose. However, there are so many types of hardware which can actually work together with this ventilator, and some of them cannot. Just have a look. We worked with this T-type, switch, and that's a metronome which helped us with the controlling and managing the system of ventilation. And we have ensured this kind of ventilation. And the demographics and characteristics of our patients, the average age, as you can see, about 700 grams, and the time of the heart rate more than 100, that is the restoration, recovery of the heart or cardiac activity happened better and sooner, 33 seconds compared to 79, compared to the traditional treatment group. And we have seen that the reliable statistically significant differences in the needed pressure in the respiratory ways and maximum oxygen which is required for the artificial ventilation, not more than 40%. In the traditional case, it was more than 70%. And we also paid attention to the following. By the way, it is also very important during this study, reintubation in children who were given high frequency and standard were, for whatever reason, less in number in the high frequency rate, probably because the child was quiet and was not disturbed. Probably because of the fact that he did not want to turn, so to say, in bed after he was taken from the delivery hall to the normal room. So please pay attention to the fact that the difference was statistically significant in the number of the lethal outcome. And this is, I think, quite a manifest achievement in favor of introducing this method. My conclusions: use of high-frequency ventilation as a starting respiratory therapy in case of the severe respiratory distress syndrome will improve the lung pulmonary resuscitation and reduces the risk of death. Of course, we are required to have more patients to make the study powered for making any other conclusions. On the other hand, we decided to pay attention to the youngest patients who were born with the body mass less than 750, and we brought into the delivery hall the high technology hardware. So the special hardware which could control this situation. A group of patients, and the average gestation age 23 weeks, from 21 to 25 weeks. And that is from the example by Anna Lvovna, plus minus 2 weeks. And the average birth body weight, 540 grams. And some of these children died, unfortunately, and we still analyzed the physiology, what kind of pressure the lungs need during the first minutes of life. You know that the unit, the hardware that we used, it had all the possibilities to monitor and to make records and show trends for all respiratory parameters. And we have learned thereby how the compliance changes or the peak pressure changes as a result of using different types of surfactants. We have tested 3 different surfactants, and we came to the conclusion that they are all identical in terms of the effect. And actually, we have received a very gradual and very tender, I would say, and very careful recruitment with the controlled respiratory volume. If you are interested, you can actually use your telephone for that code, and you may have the article in Russian and English on this subject. So we brought that hardware unit. We established the respiratory volume approximately 4 milliliters per kilo. This is the minimum starting respiratory volume, which is described in the literature. And using this device, we started ventilation to the infants who, in 98% of cases, needed, I would say, artificial ventilation in the delivery hall. And you can see all these manual methods. The baby is born and he is intubated, and the ventilator has been tested, the sensor is there, everything is prepared. And that's an example of the clinical case. A girl who was born weight of 343 grams, 23rd week of gestation age. And so the increase of the peak pressure at the 5th minute of her life, so that we can supply the required volume to the lungs. So 80 centimeters of the mercury, this is what we needed. So remember, we have already heard it, that 20 to 40 centimeters of the water column. So if we follow this protocol, then that child will still be needed almost half of what is needed from the very beginning. So he is going to live in the situation of hypoxia and have the damage of the brain.
Here the tube is shifted a bit. The apparatus increases pressure to compensate for the leakage. But if you look at this line, the child receives a stable inhaling volume. So there is no discrepancies, no disbalances. And just yesterday at 2020, we received a baby of 400 grams, and in order to try to save his life and his head as his lungs, we equip the entire train that allows us not to move the child from one place to another. So coming from the womb of his mother, he goes into this incubator, and he will live there until he improves. Also, the artificial ventilation apparatus goes there. He comes to the place, he parks in a certain parking, and he lives with all this equipment. So the child doesn't endure any fluctuations, any disturbances, and the damage of the white matter will be much less. Probably, I don't know about his lungs, so he doesn't open his eyes. He is very, very immature. He has defects of development. He has a lot of infection problems. Probably there won't be enough inhaling opportunity, breathing opportunity in his lungs. But when we introduce such high technologies, we do everything possible, make everything possible to preserve their brain, and others come to us on foot. Thank you for your attention. Questions, please. Microphone, microphone. Oh, I will repeat the question. Microphone is not working. It is not working. It is not working. Switch it on. No. Okay, the question will be later commented. And how frequently do you see pulmonary emphysema in children on artificial ventilation? The first question was not heard. There are two very important questions. I said that high-frequency ventilation is used only for children who have severe pulmonary distress syndrome. You know, it's difficult to achieve hypocapnia when the situation is severe. It is good if we, at higher levels, we have at least the norm of capnia. And didn't have hypocapnia because the lungs did not open very well. So after the baby came to the intensive care, you transferred him to the traditional ventilation. Yes, it is an important issue. I am not surprised that the main neonatologist of the Moscow region is interested in such practical issues. Before introducing surfactant, we introduce surfactant and then assess the state of the lungs, how the child reacted to oxygen, to ventilation, how high is his saturation. If saturation preserved in a good level, then we could after surfactant, transfer him to the traditional therapy. If we saw that we were to make some efforts to maintain saturation, then he or she remained on the artificial ventilation of lungs. And the second question about emphysema. It's a difficult question. We have methods of objective examination, X-ray, ultrasound, and we can make such tests to avoid the development of emphysema. When we use a high-frequency ventilation, we shouldn't be late in controlling the breathing volume. That's all. Thank you very much. And now we have a presentation in online format from the speaker in France, early diagnostics of an autism spectrum disorder, and which tool to use and which preventive measures to implement. It will be made by Bruno Suarez. Bruno, are you here?
Yes. Thank you very much for the invitation. Thank you, dear colleague, Mr. President. So I will speak about early diagnosis of ASD, what technology can be used, and how to solve two equations of ASD. So I will speak about technological means before birth and after birth. I will show you two equations to understand this complex disease, and also what to do next. It's interesting to develop new techniques, but it's important to have clinical application. And so with a pediatrician, Marie-Agnès Jeune, we developed a special technique for newborns and young babies, developmental cocooning. ASD is a heterogeneous, heritable, and common neurodevelopmental condition with sensory atypicalities, qualitative differences in social communication abilities, intense interest, repetitive behaviors. The diagnostic is actually clinical, based on symptoms that typically manifest in the second or third year of life. ASD is a chronic disease associated with functional impairment, mental health issue, and low quality of life. It's a disease which affects around 2% of the population. It's 4 times more prevalent among males than females. The etiology is complex and heterogeneous. There is a genetic and environmental factors who are believed to converge to the brain development before birth and during the first years of life. There is no routine biomarkers and no evidence-based pharmacological treatment for ASD. Behavioral interventions are time-consuming and typically of moderate effects. It's important to understand that the genetic architecture of autism is complex, and we start to use polygenic scores. It's not frequent that only one single mutated gene can give a very severe autism. This is Thomas Bourgeron. He published a very interesting book in French from gene, synapse, and autism. And with this results of genetic studies, we start to better understand this disease. So 21 years ago, Thomas Bourgeron discovered the first gene linked to autism with intellectual disability. And nowadays, more than 200 genes are identified to explain 25% of cases. Most of them are linked to the formation of synapse and to the brain, also with chromatin. Some are linked to epilepsy. I propose this first equation of ASD, a cocktail of genes and a cocktail of environmental factors, loss equal a loss of modulation of neuronal and synaptic plasticity. The question is, are ASD synaptopathies, so disease of this very small system of communication between two neurons. To understand ASD, there is two key brain regions, cerebellum, for motor control, sense of balance, and social behavior. The other important brain region is a ventral striatum, which is implicated in motor control, reward, social interaction, and selection of sensory informations. Some enlightening neuroscience data to understand how to diagnose ASD with brain technologies. Connectome neurons communicate with each other through white matter fibers and through synapses. And nowadays we are able to show white matter fibers. For nanoconnectome, for synapse, it's not the case. The other thing, it's a resting state brain states. This is an important way to understand how the brain functioning. So when we do nothing, our brain continue to work, and nowadays we are able to study this very special spontaneous brain activity. The brain is a statistician machine. The basic functioning of brain is predictive in an unpredictable universe. And for people who work with children with ASD, they know that autism children don't like unpredictable universe. And the brain calculates the probability of the movements I may need to make. So it's a basic functioning of the brain, very related to the movement. Consciousness is like in a cinema. The brain works in a discrete, discontinuous way, 10 images per second, and gives the illusion of an harmonious and continuous stream of consciousness. I'm very pleased to work with Stanislas Dehaene. He's a PhD of math and neuroscience and an expert of consciousness. He proposed 20 years ago the global neural workspace. It's a model of consciousness, very interesting for clinician people, because you can use to understand. You can use this model to understand how the brain of your patient and autistic children work. Ghislaine Dehaene-Lamberts is a pediatrician, PhD of pediatrics and neuroscience, and she's an expert of the baby brain functioning learnings. I am very pleased also to work with Antoine Delcourt, with a PhD of psychiatry and neuroscience. And with Stan Dehaene, they discovered that schizophrenic and autistic patients have a lack of access to consciousness. This is a small picture to show this phenomenon. So there is an impairment of back to anterior part of the brain for the circulation of information. So it's very interesting. They work at Neurospin Center. It's a French nuclear agency in Saclay, not far from Paris. And they develop a new MRI machine very powerful, more than 11 Tesla, very big machine. And this year we will obtain the first images for the brain functioning. So the idea is to have in vivo brain microscope. This is a machine at CEA at Saclay, and the first images from a post-mortem brain. Another property of brain very interesting to study in autistic patients, it's that the brain is a neuronal oscillator with spontaneous ability to synchronize with other brains. And this property exists from the first day of the life. And now we start to study interaction between baby and mother and parents. So, is it possible to detect autism spectrum disorder in a fetus? If the answer is yes, ASD may be associated with abnormal embryonic organogenesis, causing postnatal malformation in some children with ASD. And second, studies show that earlier detection and intervention improves long-term outcomes. Prenatal ultrasound can spot early signs of autism, but these signs are soft marker and more common in females, so it's not very convenient to use these markers. One point interesting, it's an abnormal development of cerebrospinal fluid circulation. So perhaps we will have interesting study in the future. We can also use fetal MRI. So now it's possible to study functional connectome of the fetus to understand a neurodevelopment disorder. This is a study from Netherlands on baby brain neurotypical. So it's possible to study functional connectivity in fetal brain with this method. And the surprise is that the similarity of with the adult connectome for function, 61% of similarity. So the conclusion of this study is very interesting. The fetal brain has a functional connectome close to that of an adult from the second trimester of pregnancy. It's possible also to use prenatal genetic testing for ASD. This is a Taiwan study. The problem of this system, it's not possible to give to future parents the severity of the disease, and most of mothers would terminate the pregnancy if the test is positive. So the study show intense emotional responses to ambiguous results, and it's a major problem of ASD prenatal diagnosis. So if you test prenatal genetic for autism, what to test, how to interpret the results, and what to do about them. This is a Simon Baron Cohen sentence. Everyone recognizes that genes are a part of the story, but autism is not totally genetic. Even if you have identical twins who share all their genes, you can find that one has autism and one doesn't. So after birth, is it possible to make the diagnosis of autism before 24 months? Most of children are diagnosed around age 4, and earlier identification could allow children to receive interventions as babies when they have a greater brain plasticity, and thus may receive more benefit. So the idea is to find biomarkers for early interventions and to develop more personalized treatment strategies. So it's possible to use EEG with artificial intelligence. It's an American study. And the idea to identify early differences in the signal complexity. Predictive accuracy by 9 months of age was nearly 100%. So this is a drawing who show the way to use EEG and artificial intelligence. The other technology you can use is functional MRI of the resting states of the brain, and it's also a study with artificial intelligence. And the idea is to answer to the question, which regions are synchronized at 6 months of age? And the algorithm correctly identified 82% of autistic children and 100% of those without. So the idea is also to develop early autism biomarkers for early treatment. The problem with this with studies is the machine does not reveal which brain regions or connection or area are altered in autism or their underlying biology. It's a major problem of artificial intelligence use in this health studies. Another way is to use anatomical MRI to measure intracranial, extraaxial cerebrospinal fluid in high-risk infants who later develop autism. So it's only measure of cerebral fluid in the brain of the babies. And it should be also an interesting way to do early diagnosis. Another technique is pupillometry and eyes tracking. Enhanced pupillometry reflex in infancy is associated with autism diagnosis in toddlerhood. So it's also an interesting way to study how the pupillary light reflects in these children. But there is no control studies to confirm these results. You can use also eyes tracking as early as 2 months. And it also an interesting way to study visual social attention and distinct eyes gaze pattern and abdominal eyes contact are hallmark features of ASD. So it's a dynamic evolution with a decline in eyes fixation within the first 2 to 6 months of life. And neurotypical children focus on a person's eyes, while autistic children look at the mouth. So it's also an interesting way to study babies at risk. So what to do next? The idea is to use non-stigmatizing methods and discourse for parents, take into account of significant emotional burden associated with the diagnostic of autism, and to propose a universal method of education suitable for all infants, beginning at the birth. So we propose with Marie-Agnès Chen, who is a pediatrician, developmental cocooning, the idea to start at the birth and even before, and a program from 0 to 3 years old to make the most of the first wave of baby neuroplasticity. This is Marie-Agnès working with a young baby. How to measure the severity of autism? I propose this second equation of ASD for measuring the severity of the disorder. ASD severity equal environmental factors multiply polygenic scores, multiplying brain imaging scores, and divided by resilience factors. So the idea is what are the resilience factors that will mitigate an unfavorable high-risk genetic profile in a child. So we know that lack of human contact for babies are not good for brain development and social communication. Also, babies exposed to laptop and screens have more time language delays, so it's possible to use these facts to better to propose educational programs to parents, and protecting pregnant women, mothers, and babies from chemical pollutant and endocrine disruptors. Conclusion: high technologies and artificial intelligence may make it possible to understand and diagnose autism in babies before 24 months. A combination of infants measures offer a stronger prediction of diagnosis outcomes than a signal measure. The care of babies from birth requires an efficient and competent human presence, no machine. Simultaneous tracking in early development of autism at multiple levels of analysis, genetic, brain, health, and behavior. If these screening tools can be effectively used in clinical practice, they be linked to beneficial infant intervention and ultimately improve quality of life of individuals diagnosed with autism. Our Such future studies should shed light on the question raised by parents of babies at risk of ASD. Will their baby be autistic or not? Will their baby have a severe form of autism? Will their child be independent later? Thank you for your attention.
Thank you very much, Bruno. Any questions? Вопросы? Thank you very much. И у нас последний доклад на сегодня. Влияние элементов и витаминов на развитие.
And we have the last presentation for today, vitamins, minerals, and indeed, so the Mimrikova Alexandra will make this presentation, the brain before and after birth. We are talking about this, and now we will speak of vitamins and minerals. Distinguished participants in the conference, I represent here the resuscitation unit of this hospital. Oh yes, I'm coming from the University of Friendship, and I'd like to speak of the role of the elements in the development of the CNS. It is well known that in our organism, a human organism, there are 75 chemical elements. At present, scientists keep saying that probably in our organism we have all known chemical elements. However, if we cannot find them at this moment, that means that the methods are not available to be able to identify them. More than 98% of the elements, organogenes, such as oxygen, hydrogen, carbon, nitrogen. And then we have microelements, which stand for 1.9%, sodium, potassium, calcium, phosphorus. And microelements and ultra microelements, such as iron, copper, zinc, and so on, 0.1% for those. Briefly, let me tell you that the elements are extremely important for the metabolic ways of the organism, and we in our organism have more than 3,000 of enzymes, and about 700 of them are activated by the elements. And the elements are actually parts of those, and they would influence the activity of the hormones. For instance, zinc participates in the synthesizing of insulin and so on and so forth. So they are very important in different ways, and the elements are in close cooperation with each other. There are cases of synergism, there are other cases of antagonism, and and I'm a physician, and I have to understand that when I prescribe a drug, I also change the balance of elements which the patient already has. And special elements, they are in our organism in a strictly specified amount, so to say. And so we should not have the shortage as well as the excess of those elements. I'm a specialist in neonatology and rheumatology. And of course, in my practice, I keep saying about the elements and I know how to correct all these things. But that group of microelements is still beyond the field of our attention, and probably for the reasons that population is not knowledgeable in all these things. And it is also difficult to diagnose, and also there are no readily available elements or drugs which could correct the situation. And for my presentation, I use only part of the alphabet, and you see the text, but you probably will not be able to read the message. But anyway, so here I'm showing the effect of the essential microelements for the development of the central nervous system. So intrauterine period and then postnatal period. And so you know that the development of the nervous system is going on, and iodine, zinc, selenium. So they are all very important. They play an important role in the development of the system. And this is happening at the moment when the woman may not know about the fact that she was already pregnant. And particularly studied elements which would influence the development of the central nervous system and whose balance may lead to the violation of the balance of the nervous system. So I'll speak of each of them in greater detail. Iron. Well, we hear about it a lot. However, we do not think that the control of this element in our practice is sufficient. And also, when the woman is preparing for the pregnancy, it is important that the pregnancy starts at the moment when the woman has all these elements in the required norms. And neurogenesis actually is taking place very early and according to the obstetrician's protocols. And unfortunately, I should say that they are also not filled out as they should have been. So ferritin, that's the protein which accumulates iron, should be at least 33 microgram per liter, because if it is higher, then that will be a very high risk factor for the problems or defects of the neurological development of the child. And in the intrauterine situation, all these things are very important. Iron is important. It is participating in different processes. And in the third trimester of pregnancy, children will accumulate a lot of different elements, including iron. And they will be using that stock in the first 6 months of the early development. And neonatologists should remember this. They do not always take that into account. The level of ferritin in the neonate, the norm is up to 300. So the baby is born with high level of iron. For an adult person, that would be a catastrophe to have that level of ferritin. And then this process continues at the stage of myelinization and also at the stage of formation of the hippocampus. And so we have to understand that if something is wrong from the point of view of the elements, cognitive, speech, and psychomotor development are at risk. And so once again, we should all remember about the necessity to follow the situation with the elements. And if, for instance, the child has made that stock and it is enough for the first 6 months of his life, then that's good. But if that has not happened, then the elements from the breast milk will not be sufficient. There are data which show that the deficit of iron, which may cause anemia, may, in a reversed manner, restore that situation. And there are no data which would show that the iron may correct the defects of the nervous system which were caused by the former shortage of the iron. Next element which I would like to comment is iodine. Unfortunately, from the school program and from the university obtained knowledge, so there is such an element which is iodine. But actually this is not enough. And in synthesis of the hormones of the thyroid gland, at least 6, I'm showing them, nutrients are participating plus vitamin A. I'm not going to speak about this biochemical chain in details, but please pay attention that these are the enzymes which are participating in synthesis of the hormone of, of the thyroid gland. And the disbalance of the main essential elements at critical periods of the brain maturation may lead to the problems of the development of the brain. So we have to be very, very careful. Intrauterine synthesis synthesis will depend on what the mother's organism has. And so T4 is synthesized by the baby to the form which is active in, and the woman in hypothyroidism. So hypothyroidism, according to literature, is one of the first reasons for the damage to the nervous system in children. Iodine is participating at all stages of the maturation of the brain, and negative consequences of the deficiency of the iodine during intrauterine period include intellectual deficit, the syndrome of the attention and hyperactivity deficit, and the psychic disorders. Particularly important problem and consequence of the deficit of iodine is the cretinism, which is characterized by the deep mental retardation. And according to UNICEF, annually, health of 14% of neonates all over the world, and that accounts for 19 million children, actually is subjected to serious risk of development of the mental retardation due to the shortage of iodine in the organism of the mother during pregnancy and of the child during first years of his life. Selenium, it is used and has been shown the negative correlation between the level of selenium in the blood of mother and the length of the cerebellum in the infant, and the status of selenium in the woman during pregnancy is also associated with the cognitive development and psychomotor and speech abilities of children during the first years of life.
Также на слайде указаны.
The slide also shows correlation between the level of selen in the mother's body and the cerebellum of the child. Also, it is connected with the cognitive development and speech development in the first years of life. There is data about the importance of selen in autistic spectrum disorders, manganese. So there is a list of enzymes that activate manganese. I would like to focus on one. For some period of time, we have paid much attention to hyperanemia. This is the level of ammiac that can lead to the heavy disorders, severe disorders of the hand. It can be congenital, but it can also be acquired. And the arginase participates in the urine cycle, and the deficit of manganese can lead to the cycle of to the hyperanemia. Zinc is a very important element for the formation of the nervous system. Here we see that from the first weeks, zinc participates in neurogenesis. Its concentration is high in many areas, and the so-called vesicular zinc. And also there are high concentrations of zinc in the cerebellum at prefrontal cortex, which connected with the presynaptic vesicles of glutamatergic neurons. So we had a very interesting lecture today about the autism spectrum disorders, and it is quite clear that that zinc plays a very important role here. One of the zinc-dependent mechanisms in the pathogenesis is the modulation of dopaminergic dysfunction. Zinc deficit in children at the age of 8-18 months was connected with the memory functions, memorizing function disorders. Copper is also very important. It is mainly present in basal ganglia, cerebellum and numerous synaptic membranes. It has a status of dopamine and cytochrome in the brain. Zinc, ferrum, copper, and manganese regulate neurotransmission and have an especially important effect on the dopaminergic system. But despite the importance of these elements, they are very toxic for the central nervous system in excess quantities. I would like to share the experience of the Department of the Medical Elementology in the Russian University of the People's Friendship. And we made multiple studies that demonstrated that microelements play a very important role in supporting reproductive function. The situation we found was quite indicative, and we are sure that the deficit of essential elements is connected with the development of reproduction dysfunction up to infertility. And really, women are to undertake all these tests, and they are to be their vitamin status is to be checked. Also, our department has children who have cognitive disorders, speech disorders, and we see that heavy metals may participate in the development of autism, stimulating three main processes: inflammation of the nervous tissue, apoptosis, and damage of cells by neuromediators of the own organism. So hair is tested to study the elements, and usually it is a low quantity of calcium, magnesium, ferrum, zinc, copper, and the increased content of toxic elements. It's very important to maintain the balance between essential and toxic elements. If there is a lack of essential elements, the organism begins to store toxic elements that may lead to neuroinflammation. So the effect on these mechanisms may prevent the negative effect of toxic metals. It can be done by zinc and selenium, and the excess of toxic metals against the deficit of essential elements may be connected with the severity of the disease. We would like, we have spoken about this topic at many different meetings, and we would like it to become more practical, and we make the following conclusion: that elements play the most important role in the development of CNS from the very beginning of in utero development. The child received all nutrients through the mother's organism. So the disbalances of elements are to be removed before the woman becomes pregnant. A number of reasons that can distort the balance of elements during pregnancy that might be acute or chronic diseases require the control of balance of elements in a woman and in a child after birth. The child stores part of the elements in utero in the third trimester of pregnancy and uses this store for its development until 6 months of life. Thus, the children who are born prematurely miss the period of in utero accumulation of elements and become part of the group of the increased risks as to the disbalance of elements. So the medical community has a deficit of knowledge about the role of these elements in the development of the baby. The the world practice has a wide spectrum of drugs and elements, modern drugs, combined drugs with different ways of administration that are vitally important for the following children. Premature born, those who underwent severe infectious diseases, and those who have genetically induced disbalances of the elements. Since most of the essential elements are intracellular, they are connected with the proteins. They are stored in special depots. The measurement of elements in the blood does not reflect the real balance of elements in the organism. We, practical doctors, need some precise and accessible methods to check it. It is not excluded that the measurement of metabolites can be a more reliable marker of balance of these elements in the organism. And our main thesis is that the protection of the child's health starts before conception. Thank you for your attention. Thank you, Marina Alexandrovna. Are there any questions to the speaker? Well, Maria Alexandrovna, if I understood you correctly, there is a certain balance of essential elements in the body, lead, mercury, that are contained in sea animals. If I buy a house on the seashore and begin to eat shrimps, tuna, so can I have some cognitive disorders in the future after eating so much fish? I won't give you a positive reply. The main thing is you won't have to give birth to a child. But the effect of toxic and essential elements can really affect the central nervous system of an adult. And the proteins, transporters, transferrin, albumin, if do not transport essential elements, they are full of toxic elements that we see in our everyday life. Food and the environment.
About iodine, deficiency of iodine. In mothers where they have not been diagnosed with, suppose, say, hypothyroidism, have you noticed any specific neurodevelopmental disorders, or it's in general?
Если можно помочь.
No, this is not specific. We didn't make such tests. I spoke about what we see clinically. This is the disorder of cognitive and speech functions. Thank you very much to all. I think our first day has been quite successful. At least we have clearly identified the importance and the painful issues where our studies are to be aimed at. And it is with great pleasure that we invite you tomorrow to join the second day of our conference, the fundamental day. Thank you very much to all those present. See you tomorrow.